Hi everyone, my name is Rania, and today, along with my colleague Misht, we're going to talk to you about the fourth day of the Neuro crash course. For my part, I'm talking about my part because I don't know Misht's part. I'm going to focus on the high yield stuff, the stuff that are in first aid, the stuff that are in boards and beyonds and boot camp. There's a lot of information that I skipped that is in your lecture, such as the blood supply and the venous drainage and all of these stuff. So I skipped those because you can memorize those at home. I will focus on the main concepts that usually get asked in the step 1 exam. Okay, so let's get started. These are contact information, and we're both fifth-year medical students. Okay, for my part, I'll be discussing 4 topics: the thalamus, hypothalamus, the limbic system, as well as the dopaminergic pathways. Inshallah, I'll give you a break between the thalamus and hypothalamus. After that, I'll give you a break for like 5 minutes, and then after that, we'll continue with the limbic system and the dopaminergic pathway. So starting off with the hypothalamus, or the thalamus I mean. This is your brain. Look at me please. If this is your brain, you take a sagittal section of your brain, you will get this view, the first view right here. Okay? So this is your cerebrum, your corpus callosum, this is your thalamus, and this is your midbrain. Okay? Now, if I were to take my brain and look at it from this side, I remove the frontal and the parietal and the temporal lobe. Okay? I will have this view in front of me. Okay? Because this is not cut in half. Because if it was cut in half, then you will see the third ventricle. So when you look at it from the lateral view, you will see this. This is your thalamus. Okay? And then I move further, I remove this thalamus, I move further, I find myself in the third ventricle. Okay? And I move further after, I'll find another thalamus. So there are 2 thalamus, they're connected together in between the third ventricle. Why am I emphasizing on that? Because for you to find the place of the thalamus on any of the imaging, you'll look for the third ventricle first. Once you find the third ventricle, you'll be able to identify the thalamus immediately. Okay? So basically, yes?
Can you please use the mic for the recording?
Okay. My voice is loud. Okay. So basically, you have a thalamus, a third ventricle right here, and then another thalamus, okay? And this is how they look. Oh, it goes the opposite. This is how they look. This is one thalamus, and then in between there's the third ventricle, and then the other thalamus on the other side. So you have 2, one in the right, one in the left. And in the lecture, they will tell you that the thalamus is divided into 3 parts: the anterior and the medial portion and the lateral portion. And there are different nuclei in different areas. Alhamdulillah, the mic is working.
It's echoing. I just want to make sure if this...
Okay. And they told you that the thalamus is divided into 3 parts by this white matter running through it, through the anterior, medial, and lateral. And there are different nuclei in different places. The nuclei that are found in the anterior and medial are usually part of the limbic system, so I'll talk about them there. And the nuclei that are found in the lateral part are usually part of the thalamus, the sensory part of the thalamus. So I'll talk about them right now. But is the concept clear? Like, where's the thalamus and how to find it? Okay, so let's see if it's clear or not. Why does it go back? Okay. So, what is this picture?
The sagittal view of the brain.
Okay, so it's a brain picture. What view? Sagittal view. Okay, start with the basics. Is it an X-ray or is it a gross picture?
Gross picture.
It's a gross picture. Okay, and it's a sagittal view. So, what is this?
The cortex
Cerebrum. Okay, and what is that? Corpus callosum. And this is the thalamus. In front of the thalamus, I'll find what? Third ventricle. Because this is a sagittal view, so I cut the thingy in half. How do I exit that? Okay. Why this computer drove me crazy? I don't know. Okay. So if I cut the thing in half, if I cut the brain in half, I'll be in the third ventricle. And then if I look towards the right, I'll be towards the thalamus, and if I look towards the left, I'll be towards the other thalamus. Because I cut the brain exactly in half. Okay? So this is the third ventricle. And then moving on, what is this?
The coronal section.
It's a picture of the brain. Again. Yes. And then what view is it? It's coronal section. How did you know it's coronal? You know it's coronal because you can see the lateral ventricles, both of them next to each other, and you can see both hemispheres next to each other. Okay, and at the same time you're looking at like the red nucleus and the substantia nigra, which you'll find them here. But whatever, forget about this. How did we say we can locate the thalamus? You look for what? You look for what? Okay, very good, Eva. I'm sorry. I told you I'm blind. Oh, that was good. Okay, so you look for the third ventricle. So this is the lateral, these are the two lateral ventricles, and right here we have the third ventricle, okay? So right immediately next to it is the thalamus. So you guys are good? Okay. What is this picture? Brain. Exactly. Good. What view? Corona section. Okay. And can someone come and which number is the thalamus?
Number 2.
Number 2. What's next to it?
We're gonna have the lateral. We're gonna have the third ventricle between them, and then we're gonna have lateral ventricles.
Lateral ventricle above it. Above the third ventricle. Okay? Good. MashaAllah.
Can we have your slides, please?
Yeah, sure. Do you want? Can you airdrop them? Yeah. Bless you. What is this picture?
Sagittal section of the MRI brain.
How did you know it's MRI?
Because
You can
we
see the
took
soft
MRI.
tissues.
Yeah. You can see the soft tissues clearly.
Yeah.
And the bone is not as bright that you would find in a CT. Okay, good. Which view is that? Who was that? Yeah.
Sagittal.
Sagittal view. Okay, and where is the thalamus? Which color?
The thalamus is going to be the one that is like purplish, but it's like very light purple.
Yeah. Lavender.
Lavender.
Good.
Okay.
Okay, this was before. Okay, what is this?
Brain.
Brain. Good. What view?
Coronal section.
Corona section. Okay. Where is the third ventricle?
The lavender color and the medial to the lavender color.
Medium? Yeah, medial to the lavender color. Okay, and what's the lavender color?
Thalamus.
So the medial to the lateral ventricle, lateral lavender is the third ventricle, right?
Yeah, this is the third ventricle and this is your thalamus. Okay? And this is your lateral ventricles. Okay? This one, someone who didn't answer, please.
Isn't it the same one?
No. This is one as a hard one. 2 lollipops. Answer it. Yes.
MRI.
Okay. It's an MRI of the brain. What view? Axial. Like this. Okay. And where's the thalamus?
Oh, the lavender.
The lavender. And how did you know?
Because it's under the corpus callosum, or like the third ventricle.
Third ventricle. Okay. Okay, so that's the first point I wanted to emphasize because this is how they will ask you in step 1. The 2 most important things is to identify where's the thalamus because they will give you because they will give you a scenario and they will tell you there is a problem with one of the nucleus in the thalamus. And you will know that there is a problem with one of these nucleus, but they will tell you to pinpoint the thalamus or pinpoint where is the lesion. So they will ask you to pinpoint where is the lesion on the MRI. So that's the most important thing in the thalamus. The second most important thing is the thalamic nuclei. And basically, you just have to memorize that. I'll try to help you with the mnemonics, but yeah. So the first nucleus that you guys are most likely familiar with is the ventroposterior lateral nucleus. Do you guys remember where was that?
All all the tracks in the spinal cord, they go through that part of the thalamus.
Exactly. And then there's a third neuron that goes from the thalamus to the cortex. So basically, the thalamus, it gets all the sensory information from all of the body except for the olfactory nerve. It doesn't get sensation from that. So as correctly mentioned, the ventroposterior lateral nucleus, it receives information from the spinothalamic tract as well as the dorsal colossus. Okay? So if they receive information from the spinothalamic tract, what sensations do they relay?
Pain and temperature.
Pain and temperature. And for the dorsal column, what do they?
Vibration, perception, and everything basically else. We're gonna have vibration,
Vibration, proprioception, and fine touch.
Yes.
Remove your iPad because it's expensive. I'm sorry. So it receives information from the spinothalamic and dorsal column, and it senses information for vibration, proprioception, pain, and temperature, and it sends this information to the primary cortex and which lobe?
Sensation.
Yeah.
We're gonna have it parietal lobe, I guess.
Parietal lobe, exactly. And then we move on to the ventroposterior medial nucleus. This receives information from the trigeminal nerve and the gustatory pathway. So basically if it's the trigeminal nerve, all the sensations for the face are received by this nucleus. And all the taste, any food that you can eat and taste, it receives information, passes through this nucleus, which is the ventroposterior medial nucleus. And it sends this information through a third neuron to the primary sensory cortex, the same way the spinothalamic and the dorsal column do. So my mnemonic for the ventroposterior nucleus is very pretty makeup, goes on the face. So very pretty makeup, ventroposterior medial nucleus. And then it goes on the face for the trigeminal nerve, so facial sensations as well as taste. Are you guys good with that? So let's repeat. Ventroposterior medial nucleus receives information from the spinothalamic and the dorsal column. Okay? And it's responsible for pain, temperature, vibration, and proprioception. For the ventroposterior medial, very pretty makeup goes in the face. Very pretty makeup, ventroposterior medial, goes on the face, trigeminal facial sensations, which is the trigeminal nerve. And along with the face, you have your mouth where you get food, so you taste food, which is part of your mouth. And then moving on to the lateral geniculate nucleus. Lateral from light. So light is what? How do you see light? Light.
Through optic chiasm.
Yeah, through the vision. Okay. So the lateral geniculate nucleus is responsible for your visual sensation. Where does it get the input? It gets it from the optic nerve, the optic chiasm, the optic tract, okay? And it sends it to the calcarine sulcus and the occipital lobe. Forget about calcarine sulcus. Occipital lobe, okay? So lateral for light, responsible for vision, okay? Lateral light, responsible for vision. Is that clear till now? The problem is there's nothing for me to explain, I just have to make you memorize it. And then we have the medial geniculate nucleus. Medial for music, and music is hearing. So the medial geniculate nucleus is responsible for hearing. It receives information from the superior olivary nucleus as well as the inferior colliculus of the tectum. And it sends it to the auditory cortex, which is found in the temporal lobe. What is the... Yeah, okay, I
42, 41, I guess.
The heart?
The broad spin area where the auditory.
But, yeah,
Are you asking this question?
Yeah, but I don't know the answer because I didn't memorize the Rodman's areas. So medial for music, hearing, okay? So ventroposterior lateral, again, spinothalamic and dorsal column. Ventroposterior medial, very pretty makeup goes on the face, sensation for the face, as well as taste. Lateral geniculate for light. Lateral geniculate light, vision. Where does it get the information from? From the optic nerve, optic chiasm, and optic tract. Where does it send it to? The occipital lobe. Okay? Medial for music, which is hearing. Where does it get the information? From the superior olive and the inferior colliculus of the tectum. And it gives it to the auditory cortex of the temporal lobe. Okay? And we have the ventral anterior and the ventral lateral nuclei. These sense the motion. They do not, because I said thalamus is responsible for all the sensory information. So if I move my hand, your brain needs to know where is it. So it senses the motion. Okay? So it receives input from the basal ganglia and the cerebellum, and you will actually understand how does this happen when my colleague Mist explains the basal ganglia and the fine-tuning of movement. So understand what this sensing, how do you sense the motor movement and how does it help you? Because if this is not there, your body will not be. So if you want to grab this mic, your body wants to know that it goes there, but it will not go as smoothly. There will be some fine-tuning. So this is basically done by the basal ganglia and the cerebellum. So your thalamus needs to tell your body that where is your body in space so that it can fine-tune the movement and give you the smooth movement that we are able to produce. And obviously it sends it back to the motor cortex of the frontal lobe. Okay? And my mnemonic for you will be Venus astronauts vow to love moving. So Venus astronauts, ventral anterior, and ventrolateral vow to love and moving, because it's responsible for the motor part, senses motion. Okay? So is it clear for everyone?
How can we talk, for an example, in the ventral posterior lateral proprioception, basically is when you want to know your body in space. So how is it different than that, basically?
That's the thing. Wait till the basal ganglia when it gets explained and you'll understand. So proprioception is basically, if I move your finger up and down, and then I tell you to close your eyes, you will tell me it's up or down, okay? But while moving, going through the motion, you are moving your hand, okay? While going through the motion, you want to grab this calculator, okay? If I do not have this fine-tuning of the basal ganglia, and I do not know where is my hand, my brain doesn't know where is my hand, it will go like this. It will make unnecessary movement, you know? It will go like this, and then like that, for example. It wouldn't be as smooth. Does anyone have any questions?
So this fine tuning is different from overshooting and undershooting?
Yeah. Any questions? Are you guys sure? Okay, my turn to ask questions. One person, please. Raise your hand. Okay.
Okay. Taste and face sensation will sign up into which part of the thalamus? Very pretty. Okay, wait, hold on. Very pretty. I think it's either okay. So it's not A or D. It's either B or C.
You said very pretty. Which one has very pretty? What very pretty what?
Very pretty. I think it's C.
Yeah, very pretty makeup goes on the face. So medium. Yes. Okay.
No.
I'm so tired from this, honestly. It's better if you guys come in yet.
Thank you.
Okay, next question. One from the girl side. Yeah.
Lesions involving the medial geniculate nucleus of the thalamus appear which of the following? The hearing.
Why? What's the mnemonic?
I don't know the name.
Music.
Yes.
Yeah.
Medial for music. Good job. Okay. Now we're moving on to the hypothalamus. Are you guys good? Or shall I give you 1 minute break to breathe? Good? Moving on. Okay, so we move on to the hypothalamus. So, it's the same way we did with the thalamus. You take a brain, you take a sagittal section of it, like this. You will get this view. This is your third ventricle, and behind it is the thalamus of the other side, not the side that you are cutting, you know? And then below it, you will find a hypothalamus. And then below it, you'll find the pituitary, sitting in the, you guys took endocrine, right?
Yes.
Sitting in which part? Salatergica. Good. So this is the thalamus. Again, a bigger picture. Thalamus, hypothalamus, and this is your pituitary gland, and this is your optic chiasm if you guys are interested in one way or another. Okay. Okay. Identifying the place of the thalamus on pictures is not really very important. That's why I wouldn't be very meticulous. I'll brush through the pictures fast. So again, this is the what?
Cerebral cortex.
Cerebral cortex, corpus callosum, and this is what?
Thalamus.
There you go. Wait, I don't know where's my mouse. Okay, what is this?
Thalamus.
Yes, and what is this?
Hypothalamus.
Hypothalamus. Good. Okay. What is this?
Cerebral cortex.
What is this? I'm not pointing at anything.
Ah, the orange.
No. What is the picture itself?
Brain.
Brain. Good. Well, you're focusing. It's brain. What kind of picture is it?
Sagittal.
Sagittal. Okay, good. Where's the thalamus? Right here? Is it
Yes.
No, no.
No, no.
It's below it.
right here?
Yeah.
Yeah, it should be right here. This is the third ventricle because they removed the thalamus off that side, okay? And this is what?
Hypothalamus.
Hypothalamus. And there's no pituitary. They cut it off. Okay, this is what?
MRI.
Is it MRI? I think it's. What is it called? Pretty good. Okay. Yeah, this is MRI. What cut is this?
Sagittal view.
Sagittal view. Good. And where is the? What is this?
This is the thalamus.
Okay. And this is?
Hypothalamus.
Is it normal?
No, it's enlarged.
There's a mass.
Yes.
Okay, good. Okay, now this is the most important part of the thalamus. What does it do? And the thalamus has different nuclei. Okay, the thalamus has different nuclei located in this situation, like in here in the thalamus itself. And different nuclei does different stuff. So again, there's nothing for me to do except to make you memorize them. So try to not confuse them between the thalamus and hypothalamus, because I did that. So try your best. So these are the nuclei and we're going to go through them. Okay. So the thalamus is responsible for doing tan hats. Okay? This is the mnemonic. It's responsible for doing tan hats. So it's responsible for regulating thirst and the osmolarity of the serum in your body. It's responsible for regulating the adenohypophysis, and I think you guys know that from endocrine. It's responsible for regulating the neurohypophysis, and it's responsible for regulating hunger, and the autonomic nervous system, temperature, and sexual urges. Okay? And I'll tell you which nuclei is responsible for what. But for the autonomic nervous system, we all know that the autonomic nervous system starts from the hypothalamus, and then it divides into craniosacral to be what? Sympathetic or parasympathetic?
Craniosacral.
They're
Yeah.
Parasympathetic.
Parasympathetic. And sympathetic would be? Which areas of the spinal cord?
Thoracolumbar.
Thoracolumbar. So the hypothalamus is responsible again for what? Tan hats, so thirst and osmolarity, adenohypophysis, neurohypophysis, hunger, autonomic nervous system, regulation of the autonomic nervous system, temperature, and sexual urges. Okay? So these are the different nuclei of the thalamus. Take them 2 by 2. The first 4, take them 2 by 2. So the lateral with the ventral. Okay? Because one does something, the other does the opposite. So the lateral nucleus is responsible for making you feel hungry. It's stimulated by the hormone ghrelin. Ghrelin, yeah. So if it's not working, if the lateral nucleus of the hypothalamus does not work, so you will never feel hungry. And if you never feel hungry, you will never eat. And when you never eat, you lose weight. And when you lose weight, you become anorexic. And in kids, we call this failure to thrive, most likely, but it could be used in adults. Okay? So it's responsible for making you feel hungry. Lateral nucleus is responsible for making you feel hungry. If I have a lesion, I will become lean. If I have a lesion in the lateral nucleus, I will become lean. Okay? So, what is the function of the lateral nucleus? Makes you hungry. Okay? And the mnemonic is for the lesion. Okay? Remember that. Lateral injury makes you lean. Lateral injury. Okay? For the ventromedial nucleus, it's responsible for making you feel full. And it's stimulated by the hormone leptin, which is secreted from your fat cells. Okay? So if the ventromedial nucleus is not working, exactly, I did the same thing. So if the ventromedial nucleus is not working, you will never feel full. And if you never feel full, you will keep on eating. This is called what? Hyperphagia. Okay? And when you keep on eating and you have hyperphagia, you will become obese. Okay? So ventromedial is responsible for satiety. Okay? And if I have a lesion, I'll have hyperphagia and obesity. So my mnemonic will be a ventromedial injury, VM. Injury will make you very massive. Very massive as in like obesity and hyperphagia. Okay? So I think just go with the mnemonics. Don't try to memorize the function or the lesion. Memorize one of them, and by knowing one of them, you'll be able to get the other. For me, I would just use the mnemonic, which is the lateral injury makes you lean. So by this way, I will know that the lateral nucleus is responsible for making me feel hungry. Because if I have an injury in it, I will be thin, you know? So memorize one of them. Either use the mnemonic, but don't memorize both. Don't memorize the function and the lesion. Either one of them, and you'll be able to get the other. Okay? Now, the next two. Is this good? Do you want me to repeat, or shall I move on to the next two? You're good, okay. So the anterior nucleus and the posterior nucleus, take them together. The anterior nucleus is responsible for making you feel cool. It lowers your body temperature. And it's stimulated by, and it's also responsible for the parasympathetic nervous system. Okay? So if your parasympathetic nervous system is there, your body temperature goes down because there's no line running after you, right? So it's responsible, so anterior nucleus is responsible for cooling and activation of the parasympathetic nervous system. If the anterior nucleus is not working, so you'll not be able to bring your body temperature down. So you'll have hyperthermia. Okay? You guys will hate me, okay? And my mnemonic for you will be AC. So anterior nucleus is responsible for cooling. Anterior nucleus, cooling. Anterior nucleus, cooling. Okay? For the posterior nucleus, it does the opposite. So the posterior nucleus is responsible for heating and responsible for the sympathetic nervous system. So imagine if there's a line running behind you, your heart will race and you will start running and so on, and your blood vessels will vasoconstrict, so your temperature, body temperature will rise. Okay? So if I have a lesion in the posterior nucleus, I will not be able to maintain my body temperature, so I will have hypothermia. And my mnemonic will be hot pot for you. Okay? So a hot pot, posterior nucleus, which is the P in hot pot, and heating. Hot, heating. Okay? Hot pot, heating, and yeah. Are you guys good? Okay. So try to, without looking, what is the what is the anterior nucleus responsible?
Cooling.
Okay. And what is the posterior? I'm revising the mnemonic. And what is the posterior responsible for?
Hot.
Yeah. And which nucleus is responsible for making you feel full?
Anterior.
Ventral medium. Very massive.
Yes, ventral medium.
It's responsible for making you, yeah, very massive. Okay. And which one is responsible for making you feel hungry?
Ventrolateral.
Last one.
Yeah, makes you lean. Okay. Now moving on to the last three. We have the suprachiasmatic nucleus. The suprachiasmatic nucleus is responsible for regulating your circadian rhythm, but I don't think the suprachiasmatic nucleus is working in anyone who is in med school because we literally don't have a circadian rhythm. But yeah, let's say it's there and it's working. But the suprachiasmatic nucleus is responsible for regulating your circadian rhythm. And my mnemonic for you would be sunscreen nucleus. So suprachiasmatic, S, C, and N. Sunscreen nucleus, responsible for regulating your circadian rhythm. Are you guys good?
Yeah, what is this circadian rhythm?
It's basically your sleep-awake cycle. So when you're asleep, your body knows when it's asleep and when it's awake. And then we have the supraoptic and the paraventricular nuclei. For the supraoptic and the paraventricular nuclei, they synthesize ADH and oxytocin, and they store it in the posterior pituitary. And my mnemonic for you would be SAT box. So supraoptic, ADH, antidiuretic hormone, and paraventricular oxytocin. Okay? And if I have a problem in ADH, either that I'm secreting too much ADH, what would I have? What would the patient have?
You're gonna have hypertension because or
What's the syndrome that you guys said?
Concussion?
No. High ADH. Antidiuretic hormone from the name.
yeah, low ADH means water retention is not gonna happen. We're gonna lose a lot of water. We're gonna have dry basically.
Okay, خلص, let's do it this way. Low ADH, what would the patient have?
Urinating.
You're gonna urinate a lot.
Yeah, diabetes insipidus. Do you guys remember that? Did you take that?
Yes.
Yeah. So too little ADH is diabetes insipidus, and too much ADH is symptom of inappropriate ADH secretion, where they will have a lot of water retained in the body, and their serum osmolality will be low. Is this ringing a bell?
Yeah.
It's ringing a bell,
But-
but I do not correct it.
But why would we not have hypotension if there's a problem with this? Because a lot of water are gonna be secreted and you're gonna have low blood.
There are so many mechanisms for regulating the hypertension. You have the renin-angiotensin system, you have your parasympathetic, your sympathetic. So unless it's really, really very severe, then yeah. And also the patients with what is it called? An asthmatic diabetes insipidus, they don't just lose the water, they drink water. That's why they call it diabetes. So they're replacing the fluid also. But back to our point in neuro, that's endocrine. I love endocrine. So yeah. So, I know. And then we have the supraoptic and the paraventricular nucleus. Again, the mnemonic is SAT Pucker. So supraoptic, SAT box, supraoptic ADH, paraventricular oxytocin. Okay. And finally, to the last one, we have the preoptic nucleus, which is responsible for everything else from the tan hats, which is thermoregulation, sexual behavior, and it releases gonadotropin-releasing hormone. Okay? Are we good with all of this? Let's go through it one more time. Okay. So the lateral injury, lateral nucleus, so a lateral injury to the lateral nucleus will make you lean. So this is responsible for making you feel hungry. The ventromedial nucleus, an injury to it will make you very massive. So this is responsible to make you feel full. Okay. The anterior and posterior nucleus, these have easy mnemonics. AC, so it's responsible for, anterior nucleus is responsible for cooling you down, and the posterior nucleus, hot spot, is responsible for retaining body temperature or higher, retaining heat. The suprachiasmatic nucleus, it's the sunscreen nucleus, so it's responsible for regulating your circadian rhythm, which is basically your body knows when is it awake, or when is it in the morning, when is it in the afternoon. Why is this important? Because certain hormones are secreted at different times. For example, in the morning, your body will secrete cortisol once you wake up, and in the afternoon, it will secrete melatonin, preparing you to go to sleep. So that's why this thing is important. And then we have the supraoptic and the paraventricular nuclei, which is the endocrine nucleus. We can call it that way. We have we have the mnemonic SAT blocker, which is supraoptic, antidiuretic, and paraventricular oxytocin. they make it, the hypothalamus makes it, and then stores it in the posterior pituitary. Okay? And we have the preoptic, which is responsible for thermoregulation, sexual behavior, and the release of gonadotropin releasing hormone. And also, the hypothalamus has its role in the endocrine system by releasing certain hormones. An example of that would be the thyrotropin releasing hormone, which will stimulate the pituitary to release TSH, and then the pituitary will tell the thyroid to release the thyroid hormone. I think you guys took this in endocrine, not really important here in terms of neuro, but just for the sake of completion. Okay? Any questions? Are you guys sure?
Yes.
Okay. Do you guys want to have a look at the table one last time before the questions?
Can we have a look at the diagram where you positioned all of the...
The thalamic nucleus? The hypothalamus? This one?
Yeah. Do we need to know where exactly each one is? No? Okay.
No. They would never, and if they did, that's so evil. Because they don't do this in STEP. Okay, even in STEP, they don't require you to pinpoint the hypothalamus. They require you to pinpoint the pituitary, the thalamus, but they would, thalamus, not really. Unless like it's a mass, like the picture that I showed you, then yeah. But this, I don't think so. Okay.
Honestly, like they brought you very low yield questions in it, so I don't trust them.
I don't think it will ever happen, Saha. Because I don't think a doctor would actually know where's the nucleus of each one. Because you don't see them. You need like microscope and stuff to see the different nuclei. Unless they do a specific histology electron microscopy for you, then that's something else that would be crazy. Okay. Oh yeah, questions? No. One person, please. No, خلاص. You finished my lollipops.
I don't want to. I just want to.
Another one.
BD.
What's the mnemonic?
Very massive.
Yeah. So, yeah, D, hyperphagia.
I don't need a lollipop.
What?
One is fine.
No, give it to your sibling or something. You work there. One from the girls' side.
Okay.
Is it D?
Yeah. Because it's the sunscreen nucleus. It's responsible for regulating what? The circadian rhythm.
D, right?
Yeah.
Yes.
Because the person has insomnia. Most likely you have to call. Do you guys need a break? Yeah? Go take a break. The other ones are easy. طيب, now we'll start with the limbic system, and then after that we'll move on to the dopaminergic pathways. Not as intense as the first two. Little bit of memorization. So any idea what's the limbic system? What is it responsible for?
Emotions and memories.
Okay, it's responsible for emotion and memories. Okay? So let's start. So your limbic system is made up of nuclei. Okay? The first one is the limbic lobe, which is the one right here. And it's made up of three parts. The cingulate gyrus, which is right here. The perihippocampal gyrus, and the uncus.
Can you use the mic, please?
And then the second nucleus will be the hippocampal formation, which is made up of the hippocampus and the dentate gyrus. Okay? Can you guys see? Where am I pointing at? Okay. So, for whoever was not here, we have the limbic system is made up of different nuclei. We have the limbic lobe, which is made up of three parts: the cingulate gyrus, the perihippocampal gyrus, and the uncus. And the second nucleus is the hippocampal formation, which is right here, and it's made up of two parts: the hippocampus and the dentate gyrus. Okay. And then we have the mammillary bodies, which are found here. I'm here in this diagram. This is the hypothalamus. Under it, immediately you'll find the mammillary bodies. Okay? And then the thalamus not all of it, 2 nuclei of the thalamus, because I told you about some nuclei. There's actually 60 nuclei in the thalamus, not only the ones I mentioned. So the ones I mentioned are really very few. And after that, 2 more nuclei, mainly the anterior nucleus and the medial nucleus of the thalamus. They're part of the limbic system. And then we have the prefrontal cortex, and then the amygdala, which is the one responsible for fear. And we have the septate area, and the habenular nucleus, which is this one, right here. Okay? Okay. So let's do a story moment, so that I can explain the limbic system in an easier way for you guys. Because it's emotions and fear, but we should know what is each part of the limbic system is responsible for. So, for example, amygdala is for fear, and hippocampus is for memory, and we need to know what are the others for, okay? So imagine you're walking home alone at night, when you suddenly hear footsteps behind you. So your heart starts racing, and you feel a sense of fear. So you turn quickly, and you find a very large shadow of a person behind you. And you think, maybe this person is following me, maybe this person is not following me. So you start recalling memories of news reports that people get robbed in the area that you are in. So your mind starts thinking, should I run? Should I hide? Or should I turn and confront this person? Why are you stalking me? So you were like, okay, let me make sure maybe this person is following me or not. Maybe I'm paranoid. So you cross the street and the person followed you. So you confirm that the person is actually following you. So without hesitation, you started running. You decided to start running to the most area that is well lit. And once you're inside the store, you are safe. This person is not stalking you. And you feel relieved. But your mind and your body are still trembling, and you keep on recalling this incident multiple times, although there's no danger. Okay? Is the story clear? Let's apply the story in the different parts of the limbic system. So starting off, when you heard the footsteps, we said that the thalamus accepts all the sensory information, right? So the thalamus is the sensory relay station, okay? So the example of the footsteps is because of the thalamus working. And when you heard the footsteps, you are going to stimulate the amygdala to see, is this actually, should I get scared or should I not get scared? So in this scenario, you got scared, so your amygdala was activated. So the fear and threat is the action of the amygdala. So when you detect fear and your heart starts racing and your pupils constrict and you start sweating and start getting scared, that's the amygdala, okay? When the amygdala is stimulated, you need to, now you're feeling the fear, but you need to exhibit that in your body, so you'll stimulate the hypothalamus, okay? So when the hypothalamus is stimulated, we said that the hypothalamus is responsible for the autonomic part, certain nuclei. Which 2 nuclei are responsible for the autonomic part? The anterior and? The anterior and posterior. Because anterior, remember, AC cooling is part of the parasympathetic thingy and hot spot. Posterior, which is what? Sympathetic. Okay? So the hypothalamus gets stimulated, it will activate the autonomic nervous system, and the epinephrine will be released. So your heart rate starts increasing, your breathing starts increasing, you start to become sweaty, and your pupils will dilate. Okay? When you started recalling the memories of the news and the story of people getting robbed in that area, that was your hippocampus working, trying to remember information. And then, when you started questioning, should I run? Should I act normal? Or should I turn and confront the person? This was your cingulate gyrus working, which is part of the limbic lobe, the limbic nucleus, which I explained earlier. Right here. Cingulate gyrus. And then after that, once you started running and you reached safely to the place, you kept on recalling the information about what happened, and this is usually done by the memory bodies, and that's how we relate emotions to learning experience. So for example, another example of how the memory bodies would work, if you saw a snake, although someone mentioned the snake, you saw a snake and you started running and your heart starts racing. You related this emotion to the action of getting fearful right now because of the mammillary bodies. And if I mention to you the word snake right now, obviously you will not pet it, you will think of fear. So that's how you learn. You learn through experience. So is this clear? A bit? I see blank faces. Okay. So to simplify it, the thalamus acts as it is. It's responsible for sensory information. Okay? The amygdala is responsible for fear. Literally, amygdala, once you see it, remember fear. The hypothalamus is responsible for the autonomic nervous system and the hormonal response, which is increasing epinephrine and so on. The hippocampus is responsible for memory and learning. This is what you guys use to remember any information that you need. In fact, patients with Alzheimer's, okay, the first sign of Alzheimer's is that they start to lose memory, okay, because their hippocampus is not working, okay? And then the cingulate gyrus is responsible for emotional processing and decision making. And the mammary bodies are responsible for memory relay and learning from experience. An example of how the mammary bodies, why am I emphasizing the mammary bodies? Because some people confuse between the mammary bodies and the hippocampus. For example, if you sprayed a certain perfume in a certain place, okay, you would remember this perfume again. If I smell it to you in a different location, you relate this perfume to that place that you smelled it earlier. So that's how your mammary bodies work, okay? So is it clear? Okay. Now in your lecture, I don't know if the doctor will do it for you, but there's something known as the Pepys circuit, which is basically, it's a theory that shows how the different parts of the limbic system, they're connected together and how they relate different parts of the anatomy to the emotion. So in simple terms, you have your hippocampus. It starts with the hippocampus and ends with the hippocampus. So it starts with the hippocampus, and the hippocampus is connected to the mammary bodies of the hypothalamus through the fornix, and then it transmits this information to the anterior thalamus. Can you guys see my pointer? Okay, to the anterior thalamus using the mammary thalamic tract, and then from the anterior thalamus it will transmit this information to the cingulate gyrus using the anterior thalamic radiation, and then from the cingulate gyrus back to the hippocampus again. Okay, so that's basically it. You just have to memorize this theory. Okay, but the most important thing is this. What does each part do? So in simple terms, for me, if I were to memorize something, I'll say the amygdala is responsible for fear, the hippocampus is responsible for memory and learning, the cingulate gyrus is responsible for emotional processing and decision making, the mammary bodies is responsible for memory relay and learning from experience. Is that good? Okay. Does anyone have any questions?
Can you explain the Pepys circuit again, please?
Okay. So the Pepys circuit is basically a theory showing how the different parts of the limbic system are connected together and how they can connect the emotions and memories together. Okay? So it starts with the hippocampus and it ends up with the hippocampus. So it starts with the hippocampus. The hippocampus will send the information to the mammary bodies of the thalamus, okay, of the hypothalamus, to the fornix. And then this information will go from the mammary bodies to the anterior thalamic nucleus, okay, through the mammary thalamic tract. And then from the anterior thalamic nucleus, it would go into the cingulate gyrus, okay? And then from the cingulate gyrus, using the cingulum, back to the hippocampus. Is it clear? Yes. Okay. Any questions? Okay. Let's try this one. Agnosia means you're not seeing something in space. And amnesia means you're not remembering information. Okay, so B. So it's called anterograde amnesia. So basically what happens in Alzheimer's, the first sign is that your hippocampus is not working. So the first signs of Alzheimer's is that the patient will forget the recent memories, the ones that recently happened, and that's called anterograde amnesia. And they can still remember the old memories, and then after that, as it progresses, it will get worse and they will not remember anything. But basically, the hippocampus is responsible for anterograde amnesia. Are we good? Okay. Who answered this one? Who answered this one? Answer this question. No, sit down. Sit down. Next time I don't hit you. I'm sorry. Okay. We'll move on to the dopaminergic pathways. This one is, I promise, the easiest one of them. I promise. Okay, so why do I want to know about the dopaminergic pathways? Because I'll use the example of schizophrenia. Does anyone know what is schizophrenia?
Yeah, like hallucinations and stuff.
Hallucinations and stuff. What happens exactly? Do you know anything that happens in the brain?
Increase it lead to
Increased dopamine. Who's answering? Increased dopamine receptors. Okay. Anything else? Okay. Okay, so some of the information you guys said is correct and some is not correct. And to explain the dopaminergic pathways, I'll be using the example of schizophrenia in here because this is why you're studying the dopaminergic pathway. Okay, so we have 4 pathways in the brain. We have the mesolimbic, the mesolimbic, so from here to here, the mesocortical. We have the nigrostriatal pathway, and we have the tuboinfundibular pathway. Okay? Starting off with the mesolimbic pathway. So in a patient with schizophrenia, so basically what is schizophrenia? It is a disorder of the brain where basically there is, in simple terms, there is a disorder of dopamine. There's a lot of dopamine in some areas of the brain and low dopamine in some areas of the brain. So there's no increased dopamine all over the brain. So in schizophrenia, this is the mesolimbic pathway. It's from the ventral tegmental area to the nucleus accumbens. Okay? Ventral tegmental area to the nucleus accumbens. It sends dopamine from the ventral tegmental area to the nucleus accumbens. Okay? Because dopamine is made in 2 parts. The ventral tegmental area and the substantia nigra. So for the mesolimbic pathway, there's a lot of dopamine in the mesolimbic pathway. This is responsible for the positive symptoms of schizophrenia. What are positive symptoms of schizophrenia? It's the symptoms that a patient with schizophrenia has extra, which is the hallucinations. We do not have the hallucinations, it's extra. So that's responsible for the positive symptoms of schizophrenia. So that's the mesolimbic pathway, okay? So in the mesolimbic pathway, there's a lot of dopamine in this pathway. How do I treat schizophrenia? I usually treat it with antipsychotics. What do antipsychotics do? They mainly decrease the amount of dopamine right here. So when I decrease the amount of dopamine right here, there will be no hallucinations. Is it clear? So this is the mesolimbic pathway. There's a lot of dopamine and schizophrenia in the mesolimbic pathway. If there's a lot of dopamine in the mesolimbic pathway, there is what? Positive symptoms. What are positive symptoms? The hallucinations. How do I treat this?
Can you explain like the pathway is from what and what?
From the ventral tegmental area to the nucleus accumbens. That's it. So cute. No decussations, nothing. Ventral tegmental to the nucleus accumbens. That's it. How do you treat it? You treat it with antipsychotics. Okay? Antipsychotics, what do?
They decrease the
dopamine. When I decrease the dopamine, I decrease what? The hallucinations or the positive symptoms. Is that clear?
Yes.
Okay. Continuing up with our example of schizophrenia. In schizophrenia, there is decreased dopamine in the mesocortical pathway. So what is the mesocortical pathway? It is the dopamine that goes from the ventral tegmental area to the cortex. Okay? From the ventral tegmental area to the cortex. So there's in people who have schizophrenia, there's decreased dopamine in the mesocortical pathway. What does this lead to? It leads to the negative symptoms of schizophrenia. What are the negative symptoms of schizophrenia? From the definition of positive symptoms, it's the opposite of it. So in positive symptoms, they have something extra. In negative symptoms, they lack something we usually have. So we usually have emotions. If you told me a sad story, I'll feel sad for you, right? And patients with schizophrenia, they don't feel sad for you. They don't understand the emotion, you know? So that's responsible for the negative symptoms. And that's why most of the time they'll be depressed, because they don't understand what's happening. Imagine you're there and basically, how to explain it to you? It's actually what makes us human. So what differentiates us from animals is that we're able to understand emotions. Although animals do understand emotions, but like to some extent, but we're different. So in schizophrenia, there's decreased dopamine in the mesocortical pathway. Okay? And when there's decreased dopamine in the mesocortical pathway, it's responsible for the negative symptoms of schizophrenia. Okay? Which is the depression and the lack of emotion, or the apathy, as we can say. طيب, I said we treat schizophrenia with what? Antipsychotics. And how did I say antipsychotics work? They decrease dopamine, right? So okay, they decreased the dopamine in the mesocortical pathway and the hallucinations went away, and that's good, right? But unfortunately, the antipsychotics, they do not know in which dopaminergic pathway should I decrease it. So they decrease dopamine in all of the pathways. So unfortunately, you are going to make the negative symptoms that the patient experiences of schizophrenia, much worse. But already the people with schizophrenia, they have a baseline of negative symptoms. Like, they already do not feel emotions. So even if you treat them fully with the best regimen ever, they already have this. They will already have negative emotions. They will not understand your emotions. Okay? So is this clear?
Yes.
So in schizophrenia, remember again, there's an increased dopamine in the mesolimbic pathway, and decreased, which is responsible for the positive symptoms, and decreased dopamine in the mesocortical pathway, which is responsible for the negative symptoms. Good? And then we have the nigrostriatal pathway. This is part of the basal ganglia, but in simple terms, you basically have dopamine that's going from the substantia nigra to the caudate, to the striatum, which is made up of the caudate and the putamen. Okay? So this part is responsible for fine-tuning your movements, which is part of the basal ganglia, and it will be explained right now, okay, after me, immediately. So this is responsible for fine-tuning your movement. And patients with schizophrenia, I treat them with antipsychotics. Antipsychotics decrease dopamine. So if I decrease dopamine and the nigrostriatal pathway, I'll not be able to fine-tune my movements. I will not go smoothly. So the patient will have symptoms of Parkinson's. So the patients will have resting tremor, scanning speech, shuffling gait. It's not because they have Parkinson's, it's because it just decreased the dopamine in this pathway. You got it? So the nigrostriatal pathway is responsible for what? Fine-tuning your movements. It's part of the basal ganglia. Okay? If I decrease dopamine by giving antipsychotics, I will give the patient Parkinson's symptoms. So they will have the scanning speech, the resting tremor, the shuffling gait. Okay?
Can we say that they have Parkinsonism?
Yeah, they have Parkinsonism, not Parkinson's disease. They have Parkinsonism. Is this clear?
Yes.
Okay, so just to repeat again, we have the mesolimbic pathway. I have increased dopamine in patients with schizophrenia. I have increased dopamine. Increased dopamine is responsible for the positive symptoms. And then we have the mesocortical pathway. I have decreased dopamine in the mesocortical pathway, and it's responsible for the negative symptoms. Okay? How do I treat schizophrenia? I treat them by giving them antipsychotics. What do antipsychotics do? They decrease the dopamine. If they decrease the dopamine, do they decrease it only in the mesolimbic pathway? No, they decrease it in all the pathways. So, the mesolimbic pathway, the symptoms of hallucinations will get better because there's a lot and I'm decreasing it. In the mesocortical pathway, their negative symptoms will get worse, okay? But you usually give them SSRIs for the depression that they're going to experience. We are going to affect the nigrostriatal pathway, which is part of the basal ganglia. So instead of them having smooth movements, they will have symptoms of Parkinsonism, okay? Which is the shuffling gait, the tremors, and so on. And finally, the tubio-infundibulary pathway, which is the last way for the dopaminergic pathways. I think you guys know this, but basically your hypothalamus, if there's high dopamine, there's low prolactin. And if there's high prolactin, there's low dopamine, okay? So, if there is a high dopamine and the hypothalamus, there's low prolactin, right?
Yes.
If I treat a patient with schizophrenia with antipsychotics, I'm going to decrease the dopamine and the tubioinfundibular pathway. When I decrease the dopamine, what will happen to the prolactin?
It's gonna increase.
It's going to increase. So what will the patient come and complain to you from? Galactorrhea and amenorrhea. Is this clear? So is the dopaminergic pathway clear? All of them. Okay, so let's revise together. This is the mesolimbic pathway. What happens in it?
The positive symptoms.
Yeah.
The positive symptoms. There's increased dopamine, so there's positive symptoms. Who answered?
From the ventrolateral nucleus, or what is it called?
From the ventral tegmental area to the nucleus accumbens.
Nucleus.
Accumbens.
Okay.
Okay?
Yes.
And then we have the mesocortical pathway.
From the ventral tegmental area to the cortex, and that's if you're gonna decrease dopamine, and that's gonna lead to no emotions.
They already have low dopamine in this area, and then you're going to give antipsychotics, which will decrease it even worse.
More.
Okay, and then we have the nigrostriatal pathway, the Parkinsonism. Okay, and we have the tubioinfundibular pathway, which is
Which is basically when you're giving them antipsychotics, that's gonna lead to decrease in the dopamine, and that's gonna increase the prolactin, which is gonna lead to amenorrhea and galactorrhea.
yeah. Oh, she's not paying attention. Okay, so is that clear for everyone?
Miss Billy, I'm having enough with lollipops.
Okay, so these are the pathways. Basically, it's just a written way of everything that I mentioned in the diagrams. If you guys want to refer to that, and what's the indication for those. So that's basically why you want to learn the dopaminergic pathway. That's the only reason you want to learn it, for the antipsychotics and what happens in schizophrenia. And obviously in Parkinson's disease, because you have decreased dopamine and the nigrostriatal pathway. Okay? Any questions?
No.
My turn to ask questions.
Mesolimbic.
Mesolimbic, yes.
Mesolimbic. Okay. Right. Because there is what?
Increased dopamine.
Who answered? Who said increased dopamine? I know.
Who said increased dopamine?
This is really very far.
Okay, over here. Oh. I held it.
Okay. Last one.
Wait.
What?
We want a video of someone reading the question answering.
Huh?
We want a video of someone reading the question.
Okay.
Should I answer this one?
Yeah, go ahead.
Oh no, never mind. If you want a video, then.
Who wanna read the question?
Stop, answer the question now. And
D,
then.
it's nigrostriatal.
Okay, good.
That's not the one.
No, wait. I'll do it.
But can I tell you like why all are wrong? I feel like it would be better, easier.
Okay.
So
Read the question.
Wait, sure. Actually, yeah.
no, because like we say which one is better. So a lesion, which of the following pathway would lead to I hate reading these kind of words. And all of these symptoms, which Parkinsonism. Okay, can you this part? I know it's gonna be Parkinsonism, akathisia, and dyskinesia. Okay. So a lesion in which of the following pathway would lead to Parkinsonism, akathisia, dyskinesia, and chorea? I guess I don't know what's that. Now, as my colleague said, it's Niagara's trial because that's gonna basically, if we're gonna have decreased dopamine, that's gonna lead to having these symptoms. But if we're gonna have like the reason why it's not C, it's because if we're gonna like have decreased dopamine, we're gonna have high prolactin, which is amenorrhea, and that's not one of these symptoms. And the reason why it's not mesolimbic, because in mesolimbic we're gonna have high dopamine, and that's gonna lead to, like as my colleague said, we're gonna have hallucination, and mesocortical is gonna lead to decreased dopamine, which means that we're gonna have depression in symptoms. So that's why, as my colleague said, D is right.
Okay, but just a clarification, the mesolimbic and the mesocortical, the high low dopamine thingy is in schizophrenia only. Me and you were all normal.
Yeah.
These parts of the dopaminergic pathway are responsible for the reward center. So once you do something, you'll feel happy and accomplished. Okay? So I think that's it for my part. Moving on to Misht.
Do you guys want a break?
No, it's okay.
Are you sure? I think after this one we're gonna have a break because it's pretty big. You guys took this lecture, right?
Yes.
Do you remember a little bit?
Hard, not really.
It's
It was the first lecture I did them in there.
It's hard even for me, so it's fine. Okay. I have to use the mic?
Yep.
Okay. So, wait, why is it like that?
Yeah, the question, the arrows are the opposite because it's in Arabic. So
Can
use
I
the
have
mic. Use the mic. Use the mouse, I mean.
Mouse?
Yeah.
How do I make the pen? Do you know?
The pen. I don't know.
Okay. So I'll be discussing the basal ganglia and the cerebellum. Okay, so what is basal ganglia? Do you guys know? Do you guys know? Is it working? What?
Is it on the red part? Or can you like put the thing here?
Okay, good. So what is basal nuclei or basal ganglia?
It's basically
nuclei responsible for initiating movement.
Yes, perfect. And what is it? Is it gray matter?
It's gray matter.
Gray matter. It's in the name, right? It's nuclear, right? Oh, this is gonna annoy me so much. Wait, how do I go back? Sorry guys, 1 second. Okay.
No. عرض الشرائح.
Which one?
Misht towards the left. Towards the right. Right. No, go right. Like maximum. More. Right and
Is it that?
the comment one.
No, never mind. What comment one?
Oh, this one.
Here? Oh.
No, the move. Yeah, this one.
Okay, so basically, it consists of gray matter, and it's within the cerebral hemisphere. I'm going to show you a 3D structure in a minute. And like your colleague said, it's initiation of movement, and it's also for modulating movement. So what does that mean exactly? You guys are sitting down, right? You're resting, your arms are not flailing everywhere, right? You're able to control your muscles. So that's by the basal ganglia or basal nuclei. So it's able to control your muscles at rest, and it's able to, like Rania mentioned, it's able for you to generate movement without having any unwanted movement. So that's the basal ganglia's main job, is that it prevents any unwanted movements. A third thing is it also functions as to adjust posture. Okay? In step 1, they ask you a lot about these names, so make sure you know them. So these are all the nuclei. You have the caudate and the putamen, and they're also called the striatum or the striate nucleus. I'll show you an image later. Between these two nuclei, there's like this striated appearance, and this is why they call them the striate nucleus. The putamen and the globus pallidus, which the globus pallidus consists of an external part and an internal part. Both these two structures, they make the lentiform or lenticular nucleus. And then all these three structures, they're called the corpus striatum. So make sure you distinguish between the corpus striatum and the striatum, they're different. And then lastly, so these three structures, they're located typically within the telencephalon. So within the cerebral hemispheres, right in the center, it's really hard to see. The subthalamic nucleus is located within the diencephalon, so it's below these three structures. It's not close to it, but it's linked to the basal ganglia functionally. So it's part of the motor loop, if you guys remember from your lecture, which I'll get into later. And then you have the substantia nigra, which consists of two parts. There's the pars compacta and the pars reticulata, and this is also, as Rani mentioned, important in Parkinson's disease, which I'll explain more in a minute, okay? And then there is the nucleus accumbens. So nucleus accumbens is part of the mesolimbic pathway that you guys just heard about, right? So it's mainly the limbic system, the rewards pathway, but the basal ganglia, the main job is motor movement and modulating motor movements, but it also has loops to the limbic system, loops to the prefrontal cortex, loops to the frontal eye field. So it's also done. It also helps with cognition, with the rewards pathway, and with other pathways. So it's not just motor, but that is its main function. Okay. So again, if you guys remember, caudate and putamen. Don't look at the screen. Caudate and putamen makes up what? Striatum. And then the putamen globus pallidus. Lentiform or lenticular, yes. And then all three? Corpus striatum, good job. Okay. Okay. So first I want to show you this. I don't know if it's going to work. I hope it does. 1 second. Okay, it's not going to work, but hopefully when you guys open it,
It's not there.
it's not.
What about the box with the arrow?
This one?
need to sign into your Gmail.
Oh.
Okay, you know what? Let me switch it up here and see if I can just do it from here. Because it's really important. I feel like once you understand the 3D aspects, you're able to know everything else. Okay. So this is the basal ganglia, right? So it's located deep within the cerebral hemisphere. Okay. Now I'm going to show you each nucleus that we just mentioned before. So you have the caudate. So I like to think of it as like a hookworm. So you have like this sort of C-shaped structure, right? This is it from the different side points. And then caudate, you have the putamen, which is more lateral. So it's lateral to the caudate, correct? Also note that here in the middle, between the two caudate nuclei, is the lateral ventricle. Okay? Then you have the globus pallidus. So look, the putamen and the globus pallidus makes up what? Lentiform, right? So look, the putamen is outside. When I click on globus pallidus, it's inside. So it's just the inner portion. It's more medial compared to the globus pallidus. You see right there? Okay. And they're separated by these thin sheets of white matter. Again, all these nuclei, they're gray matter. But when it comes to the lentiform or lenticular nucleus, they're separated by thin sheets of white matter, and that's why you are able to differentiate putamen from globus pallidus. Okay?
So the putamen is part of two structures, the striatum and the lentiform, right?
Yes, perfect. Yeah, so the putamen is part of the striatum, because you consider those two as a striatum, and then it's also part of the lenticular or lentiform nucleus, yes. Okay, so now let me show you the subthalamic nucleus. You guys remember the thalamus? Okay, can you see the shadow right here? I can show you the thalamus later, but the subthalamus is in the name. It's right below the thalamus. And then you have the substantia nigra, which is right below the subthalamic nucleus. So they're like small, tiny pebbles. And the substantia nigra is the lowermost structure. It's located within the midbrain of the brainstem, versus the subthalamic is within the diencephalon. Okay. If I show you the thalamus, 1 second, because it's also important. What's in between the two thalami? Third ventricle. And what's between the two caudate? Lateral. Okay. So we said caudate is C-shaped, right? So it curves around the thalamus. I'll show you right now. But it curves around it. Do you guys, okay, right here. See? So you see the caudate, it curves around the thalamus. Plus? Okay. Oh, lastly, the nucleus accumbens. So the nucleus accumbens is also called the anterior striatum or the ventral striatum. But like I told you, it's mainly involved in the mesolimbic pathway, so it's not as involved in modulating motor movements as these other nuclei. Okay, this is the nucleus accumbens. It's located below the caudate. You can see the caudate. Let me show you all of these structures together one more time. Okay? So I'm going to point and you tell me what it is. This structure right here.
Caudate.
This one.
Thalamus.
No.
This is the
Thalamus is right here, and
Some
it's
parts
right.
beside-
It curves right around the caudate.
Is it the putamen?
Huh?
Puta,
Yes, putamen, or you can also say globus, the lentiform or lenticular nucleus. Right, this one. Yeah, it's lateral to the caudate. So the putamen and the caudate, they're separated. They're not. They don't connect, except they do connect anteriorly. It's not shown here, but they do connect anteriorly. And like I mentioned before, there's a striated appearance because you have these bridges of gray matter connecting the two. Have you guys seen those images of like, I'll show you too. But you have bridges connecting these two structures as well. And then what is this pebble, the top uppermost?
wait, which one?
It's
I don't, no, not amygdala. I mentioned there's one in the diencephalon and one, who's talking?
Substantia nigra was the lower one.
Yes, substantia nigra is the lower.
Subthalamic.
Yes, perfect. Subthalamic nucleus is right below the thalamus, and it's this one, and then right below it is the substantia nigra. Okay, we can move on. Yes,
I'm
okay.
looking at the nucleus.
I'll show you more images. Okay. Okay, so again, you're gonna have the caudate, and these are the bridges I'm talking about between the caudate and the putamen. I'll also show you different sections. And then this is the globus pallidus externus. So the globus pallidus is also divided into external and internal. So externus is lateral, internus is more medial. Then you have the thalami, which the caudate curves around. It's not seen as great as the one before, but try to remember the 3D image, or the 3D animation. And then you have the fornix, which is involved in the limbic system. I'm not going to go into that much detail for this one. And then there's the amygdala, which the fornix joins with, and then the hippocampus. What else? Did I miss anything? I think that's it. Okay.
The globus pallidus, it's the green stuff or the blue? Both green and blue.
The globus pallidus is there's the external portion and there's an internal portion. So yeah, so it's the blue and the green. Okay, so again you have the caudate. This is the thalamus. The thalamus is right.
Wait,
It curves.
I think you messed up because like it says here the putamen is the blue. I think it's the green and the yellow.
Wait.
I'm so sorry.
No, you're fine. Which one?
The globus. You
Oh
said
yeah,
that
yeah. So sorry. Yeah. So putamen
putamen is the blue.
and then globus pallidus. And don't forget that there's an externus and internus.
Yeah,
Yes.
internus.
Good job. Correct.
Those first.
So you have the caudate, it curves around the thalamus. Then you have the lentiform nucleus, which consists of globus pallidus, medially and laterally, the putamen. And the caudate, it has a head. So the head is the largest portion, and it's located anteriorly. You have a body, and then you have the tail, which makes sense, right? So I'll go over this later, but let me ask you guys questions first. So what is the lentiform nucleus? Who can answer? Go ahead.
I
Or,
think someone raised his hand. Sorry.
yes. Black abaya. If you want to try.
It's B. Yeah.
B.
It's A.
A, yes. So lentiform is putamen and globus pallidus. Okay? Globus pallidus and striatum, they don't have a name. What's striatum again?
The first
Putamen and caudate, yeah. So it's really, it's like a brain, it hurts your brain, but over time you're going to get it, okay? Okay, and then what makes up the corpus striatum? Who would like to answer? Yes.
all three structures: caudate, putamen, and globus pallidus.
Perfect. So which one of these choices? It's a little tricky.
B.
B, perfect. Because lentiform is the putamen and globus pallidus. Okay. Which of the following is the prime? Yes.
Dr. Mish, can you give them lollipops?
I don't think I'll come up. Yeah. Guys, I'm a really bad thrower. Okay, Laura first. Perfect. Wow, that was fun. Alice answered? You did too in the beginning. Blue, yeah.
Did I?
جاوبت في البداية.
Thank you.
أنا خالص معلش. Okay.
Can I answer this?
Yes, go ahead.
So, which of the following is the primary function of the basal ganglia circulatory? It's the modulatory movement, which is
Perfect. And what does that mean?
which means that it helps us like if we wanna take a couple of tips as
Yeah, so it prevents any unwanted movements. Do you remember in the choices you read chorea, right? So chorea means dance-like movements. And have you guys ever heard of hemibilismus? It's like when your arms are flailing around. So that's basically when you have lesions in the basal ganglia, then you're going to have these unwanted movements that you can't control. So that's why the main function of the basal ganglia is modulating movements. Okay?
Isn't that dyskinesia? Or are they?
They're all grouped in dyskinesia. Dyskinesia in the name means dysfunctional or abnormal kinesia movement. So all these chorea, tremors, all these are considered abnormal movements or dyskinesias. Okay? Who wants to answer this one?
if no one
Just
answers
see.
it.
Yes. No, wait.
Yeah, see?
Which of the following structures must completely compromise?
Yeah, see?
I think it's
No.
Or B?
Yes. You guys want to read that again?
Because it's the corpus striatum and the two nuclei.
Exactly. So the corpus striatum includes these three structures. You guys missed the subthalamic and substantia. Do not forget they're part of the basal ganglia, okay?
Doctor, what's the function for subthalamic nucleus?
So subthalamic nucleus, I'll show you later. There's a circuit, and it's involved in it, and it's involved in modulating movement. So all these nuclei, the caudate, the putamen, the globus pallidus, the subthalamic, and the substantia nigra, all of them work together to modulate your movements, and it does it through two pathways, which I'll discuss. Okay, and then lastly, I'm gonna hurt your brain one more time. Striatum.
A.
Yes, perfect. Got it. Hello.
There's number 6.
Okay, one last one, yeah. So, which two structures are found in the temporal lobe? You guys discussed it in the limbic system.
D.
A, amygdala and hippocampus, yes. Thalamus is not in the temporal lobe.
Where would we consider it to be?
Diencephalon.
Oh.
Or at the base, yeah. Okay, so this is the coronal or frontal section. Rania mentioned, how do you guys differentiate between coronal and frontal, or coronal and horizontal?
Lateral.
You would see the two hemispheres. So that's one way. Another way is that you would only see one longitudinal fissure. If I show you a transverse, so transverse you see two, right? Two longitudinal fissures. Or the horizontal, I would see two longitudinal fissures. Just going back. Yes, it's going back. Okay. Another thing is for coronal, you see the corpus callosum. Okay. So that's two things to differentiate it. For coronal, you see one longitudinal fissure, and you see the corpus callosum. So here we said for the caudate, it's located right next to the lateral ventricle. It makes up the wall of the lateral ventricle. You have the head, the body, and the tail. Okay, so the head makes up the anterior horn of the lateral wall of the anterior horn of the lateral ventricle, semaful. The body of the caudate makes up the lateral wall of the body of the lateral ventricle. And then you have the tail, it makes up the roof of the lateral ventricle. So the lateral ventricle and the caudate follow each other basically. Okay? Now this is what again? Caudate, okay? What is this one?
Lentiform.
Lentiform, exactly. There's a striated appearance between the lentiform and the what?
Caudate.
No, sorry, there's a striated appearance between the caudate and the what?
Oh, putamen.
Putamen, yes. So here it shows it like it's also involving the globus pallidus, but it's not. It's just the putamen that has the striated appearance with the caudate, which is why it's called the striatum or the striate nucleus, okay? This is putamen, this is globus pallidus, okay? You're gonna have this thin sheet of gray matter called the claustrum, okay? Between the caudate, this is the caudate, and the putamen, there is this white bundle tract called the internal capsule, and it's what connects the cortex to your brainstem and spinal cord. So it's like a highway of information between the cortex and the rest of your body. Okay, so all the fibers, all the axons of the cortex, they go through this internal capsule. It's really important. Outside of the putamen, but between the colostrum, is something called the external capsule, which is also white matter tract.
You said external capsule?
Yes. There's the internal capsule, external capsule. So it's between the putamen and the colostrum. Okay? Then here, what is this one? Do you guys know?
Sublentiform?
No, it's the insular lobe.
Insular cortex. Yes, insular cortex. How do I see the insular cortex? It's going to be beneath which lobe?
Temporal.
Temporal, exactly. So the insular cortex is here, and this is the temporal lobe. And the colostrum is that thin sheet of gray matter that's in front of the insular cortex. So we mentioned this is the internal capsule, which is between the caudate and the putamen, or the lentiform, you can say. Then you have the external capsule, which is between the colostrum and the putamen. Then you have the extreme capsule. It's extremely far out, which is between the colostrum and the insular cortex. Okay?
Insular cortex? What's the insular cortex?
So do you know there's the temporal there's all these lobes, right? When you want to see the insula, you have to open the temporal lobe to see the insula. And then this is the insular cortex. It's involved in hearing and other functions. Okay. What else did I want to say? What is this one right here?
Third.
Lateral.
Lateral. Yes, lateral. And then
Doctor, what function is associated with the insular lobe?
Gustatory.
I think it's the one that I think it collects all the. It's like a center, like it's for hearing and stuff. Because it's right beneath the temporal.
It's responsible for like the vestibular pathway and the tasting and the autonomic nervous system. It has so many functions.
Yeah, it's like a center for many connections. Okay. But just know it's right beneath the temporal. Okay. So again, allow me to go over the capsules first, which is white fiber. What is this one right here?
Internal.
Internal. And then this one?
External.
External. And then this one?
Latin or
Extreme.
extreme?
Extremely far out. Okay. And this one?
Caudate. Lentiform. Wait.
Don't say lentiform. I want specific. Putamen. And then? Globus pallidus. So putamen, we mentioned, I showed you in 3D, it's more lateral. Globus pallidus is more medial. Okay. So, what is this right here? So that's the easiest way to differentiate basal ganglia, by first identifying the lateral ventricle, because after that you say, what is this? Caudate. Perfect. And then we said caudate curves around what? Thalamus. Curves around the thalamus. So these bulges right here, thalamus. What is this one right here?
Third ventricle.
Third ventricle. Perfect. And then you have this one right here. What is this?
External capsule. Colostrum.
So all the capsules I mentioned are white matter. This is gross. So white is white, gray is gray. What is it?
Colostrum.
You can mistake it for that, but it's not. It's actually the lentiform, because it's very tiny in this cross section, but it's lentiform. Okay. Then this one right here. Internal capsule. Okay. And then, so the substantia nigra, this is the substantia nigra I'm telling you because it's going to be hard to differentiate it, but the substantia nigra, to remember it, it's actually dark in appearance and gross because within the cells they contain neuromelanin, which is a dark pigment. So that's why in gross inspection you're going to see this dark pigment on it. Substantia nigra is located within what?
Midbrain.
Midbrain, yes. Perfect. Okay. So what is this? Corpus callosum. And then this one? Lateral ventricle. What's right next to it? Caudate. Okay, and then what is this outer one? Putamen. And then what is this one? Globus pallidus. This is what? Externa.
Internal.
Perfect. And then here, this one?
The extreme
Gray is gray, white is white. So all the capsules I mentioned, they're white matter. Okay? This one is gray. If I showed you this, then it would be extreme capsule. You see this white layer right here? So this one, what is this?
And can you point out the internal and the external capsules?
Okay, so we said internal is between the caudate and let's say the lentiform, okay? So this is the internal capsule. And just to know it, is the internal capsule connects the cortex to the brainstem and the rest of the body. If you have a lesion here, it can affect all the axons going through it from the cortex, right? The external capsule is outside the lentiform. It's right here, but it's before the clustrum. So clustrum is a sheet of gray matter. This is the clustrum. Right before it is the external capsule, and then right behind it and in front of the insula is the extreme capsule. It's extremely far out. Okay.
Doctor.
Yes.
What are the fibers that passes through the external capsule?
هو كلها axons. So it's all, because we mentioned that the cerebral cortex is gray matter, right? So all these white matter, they have to connect somehow, right? They connect to other areas of the brain. So this is the external, this is all the white matter here. It connects to both cerebral hemispheres, connects to other lobes. But the internal capsule specifically, it's what connects the cortex to the brainstem and the spinal cord.
Yeah, but like the internal capsule, you know, like specific tracks that passes through.
Internal capsule? External capsule.
But
So how, I'm not sure.
okay.
I don't think there are specific tracks. I just think it's between lobes, like the temporal connects to the parietal, for example, through the external capsule. Okay. What else? What is this one? It's a little hard.
Optic
Optic chiasm. Perfect. Okay, and then this one. This is insula, which is located deep. It's to see the insula, I would have to remove this lobe. Temporal. So this is temporal. Okay. What else? What else? So, do you guys know what candy corn is? Candy corn.
Is that Halloween candy?
Yes, Halloween candy. So how I remember the lentiform nucleus, especially on coronal section, is through this. So like you can think of it as this is the putamen, globus pallidus externus, and the globus pallidus internus. You can kind of see it here. But yeah, it tastes awful by the way. Okay, so questions? Who would like to answer?
External
Okay, let me read it. Lateral to the striatum and medial to the insular cortex. External, yes. Laterally, which white matter tract is laterally between the clustrum and the insula?
Extreme.
Extreme.
There's an extreme capsule.
Mm-hmm. You want to go through that again? So here it's between the striatum, which is caudate and putamen, and then you have the insular cortex, but medial to the insular cortex. So right away when I think of that, like I think it's lateral to the striatum, I'm going to think about external capsule. But if I said it's past the clustrum, I'm going to think about extreme capsule.
Then why does it say gray matter?
Because it's gray matter now.
When you saying the capsules are white matter?
No, I had to change the question. Sa. This is why I need to put the questions here so I can focus. 1 second. Coronal. So which sheet of gray matter lies lateral to the striatum and medial to the insular cortex? What is it? Clustrum. Yeah. Thank you so much for catching that.
He deserves 2 lollipops for every
Yeah.
round.
I'm good, thanks.
That was really good. Yeah, okay. So white matter here, we said it's laterally between
Extreme.
No guys, wait 1 second. It's lateral between the colostrum and the insula. Yeah, it is extreme. Why is it? Yeah, it is extreme. Okay. My white matter through the basal nuclei and it carries in, this is easy. Internal. Yeah.
Is it the same as corona radiata?
Who corona radiata converges to form the internal capsule. Which of the following structures of the basal ganglia is located in the midbrain?
Substantial angle.
Perfect. Okay, now this is axial or transverse section. As mentioned, you're going to see the 2 longitudinal fissures. In this section, because look where it is lying, right? I'm not going to be able to see 2 structures of the basal ganglia. What is it?
Can we have 5 minutes?
Yeah, of course.
Like we can return
Tamam. So guys, for the transverse section, all you have to note really, the only difference is that you're able to see the U-shaped structure of the internal capsule. Okay. So in the transverse section, the horizontal section that goes like this, right? You're taking a section from the center of the brain like that, and you're looking at it transversely or horizontally. The main difference is the internal capsule, which we said connects the cortex to the brain stem and the spinal cord. It's going to be V-shaped to U-shaped, okay? And it consists of an anterior limb, a genu, and a posterior limb. Perfect, okay? So you guys know that. I would also like to point for the transverse, how would I know? It has two horizontal fissures. So it's one horizontal fissure, and you can see it on both sides, the front and the back. And then here, a trick question, but what structure, so this is the section right here, what structures I'm not able to see in this section? That's of the basal ganglia.
A substantia nigra?
Yes, and?
Subthalamic.
Exactly. Why? Because those are located below. Here I'm cutting right here and I'm looking at it from the top. So the substantia nigra, which is in the midbrain, and the subthalamic, which is in the diencephalon, is going to be below this section. Close? But you're able to see the caudate, the putamen, and the globus pallidus. Okay. Oh no, this is not what I wanted. So just one question. Okay, so this one question answered.
Typically visible? Globus pallidus.
Yes.
Perfect. I also forgot to mention that amygdala, which is which lobe is it located in?
Temporal.
Temporal. So you're not going to be able to see it in that section. That's horizontal right in the middle, okay? Okay, physiology. Are the rest coming soon? Because this is the most important part.
I think there's
Can we
like
wait like
Yeah,
5
should
more
I call
minutes?
them?
5 more minutes, خلاص عادي. But please, this is really important. I really want everyone to leave here knowing this because I spent time.
really appreciate it though.
Yeah, of course.
شكرا كثير والله.
عادي, of course.
You don't want to eat.
I'm calling the group chat.
Why? There's
Don't
like
call it
90
group chat.
people.
It's fine, like, don't call it, it's okay.
There is 90 people and none of them is coming. Shame on them. أحسن صراحة. I want to gatekeep it, you know?
No.
Low key, because like we get better than them.
No,
I'm
no.
competitive guy.
This is not for gatekeeping at all.
No, honestly, you guys are doing amazing for coming here. You guys are going to come tomorrow too, صح?
بكرة ما عندنا.
Tomorrow we do not have a session
Why?
because Red Sand Dunes was clashing, so we postponed it to next week.
But honestly, I really commend you guys for doing this. Like,
Doctor, how long will it take till the end?
I would say 30 minutes. I'm hoping. 30 to 40.
So like by 4:15?
Yes, 4:15. Yes.
If we're waiting for 5 minutes, should I just
I think what I'm going to do is for the cerebellum, you guys can read the rest of the slides, but
I know for me personally, I don't mind staying more.
طيب
طيب اللي بده يروح يروح واللي بده يضل اشرحي له بليز تمام.
بس أنا بدي أروح. أمزح I'm joking.
Cerebellum is basically 2 lobes and a vermis. And we're done.
Yeah.
خلاص if you don't want بس بنسوي.
I'm going to do it.
Tell the guys to come, please.
بس
طيب ما
أنا
عندي like save no offense. Where did you guys disappear?
Call them.
رايح رايح.
Do you know
خلاص.
the rest of the
خير صباح.
Yeah, they're coming back. خلاص.
Like a lot of people are thinking so far. Like a lot. Even around like 5-7 people from different batches. Like we didn't do crazy.
It's good. Thank you for the lollipops.
Yes.
They're important for replenishing the glucose that you are using to understand this.
Is it gonna make my mouth blue?
Yeah.
Do you want us to should amazing?
Did everyone get lollipops or no?
I got.
It's so yummy.
it was
It's
such a
not
treat,
like
you
the
know.
ugly ones.
We don't get
Well,
animal
I have
housing
ugly
in
ones.
class anymore at uni.
Yeah, but
That's an ugly one.
like the coda and these. I like the coda. No, thank you. I like this one.
I want.
You're gonna keep the entire recording like this?
Oh, we're gonna crop it later.
Okay.
Because there's a lot of stuff that's happening, I'm not even getting to it. Doesn't sound very professional.
No, next time they will be motivated to come. It should stay there.
You know, we kind of find the jobs when we graduate. So throwing stuff at people wouldn't really make us find a job.
Okay, I'm gonna start. It's fine. If they want to understand it, I can repeat quickly, but okay. So now on to the physiology, which is the modulation of the movement. So how does this occur? Okay, so you're going to have first your premotor cortex. It's the one that initiates, that wants to plan a movement. For example, I'm looking at this microphone, I'm saying I want to grab this microphone. So this starts in the premotor cortex, this thought. The premotor cortex then sends this signal to the basal ganglia. The basal ganglia, when it's activated through two pathways, it's going to activate certain muscle groups to grab this microphone, and it's going to inhibit other muscle groups to prevent any unwanted movements. So what does that mean? So I'm grabbing the microphone, I need to, like, let's say for simplification purposes, I want to flex my fingers, right? So the basal ganglia is going to stimulate the cortex to only allow the finger flexors to contract, whereas the extensors to be inhibited, okay? If I had my whole arm contracted, I'm not going to be able to grab the microphone, correct? So that's basically the basal ganglia's job, is to control muscle movements so that you have a precise movement. Tamam? So the direct pathway is when you have the stimulation of the motor cortex. In other words, you're having the finger flexors working. The indirect pathway is when you have the inhibition of the finger flexors, right? Inhibition of the motor cortex. So this occurs at the same time or one over the other? What do you guys think?
At the same time.
At the same time. So perfect. So you need both pathways to work at the same time to generate a complex movement. Okay? What else I want to say? So how does the basal ganglia make sure that only the finger flexors are like working and the rest of the body is rested? The rest of the body is not moving. So there are specific neurons that are activated that then synapse with specific neurons within the thalamus, which I'll show you later. And then the thalamus synapses with specific neurons in the motor cortex, following the motor homunculus, right? More medial is the lower limb, more lateral is the upper limb and the face, okay? So that's generally it, to simplify it. Okay, so here you have the basal ganglia connections. So the cortex wants to stimulate the brainstem and the spinal cord to generate a movement, okay? And the thalamus wants to stimulate the cortex to do this movement. But at rest, we're not moving. Why? Because you have two structures dumping GABA onto the thalamus to prevent the generation of any unwanted movements. So what are those two structures? You have the globus pallidus internus. Remember we said globus pallidus, there's an internal part, external part. So the globus pallidus internus and the pars reticulata of the substantia nigra, they both release this GABA. What is GABA?
It's an inhibitor as well.
Perfect, okay? So it inhibits the thalamus so that you don't have, oh no, you don't have any unwanted
Yes, I do.
movements. I think this one works, what are the? Okay. So we got the gist of it, right? So now if I want to do a movement, I want my finger flexors to work, what would I inhibit? Internus and the pars reticulata. That's what I would inhibit so that there's no GABA going to the thalamus. Khalas, that's the direct pathway. Okay, so you understand how the direct pathway is. So this is the general pathway, right? You have the premotor cortex that says, I want to grab this microphone, which then goes to the striatum. Then the striatum will send an impulse to the globus pallidus internus or the substantia nigra pars reticulata that then goes to the thalamus and then to the primary motor cortex. So in the end, just focus on the globus pallidus internus, the thalamus, and the primary motor cortex, which is what causes movement on the contralateral side, right?
I'm a little bit confused.
Mm-hmm.
So basically, when we want to we want to grab something and we want to flex it, right?
Yes.
We're gonna inhibit the extensors. So basically here, we're inhibiting the striatum, we're inhibiting the everything, basically, by secreting GABA, right?
No, you're stimulating, I'm going to go into that, but you're stimulating the striatum, but you're inhibiting the globus pallidus internus. Because remember, the globus pallidus internus, as substantia nigra, at rest, they release GABA. They inhibit the thalamus from moving. So if I want just the finger extensors to work, then for those specific neurons, I'm gonna not have GABA on them, and I want them to stimulate the thalamus, to then the thalamus stimulate the motor cortex for the finger extensor muscles. Perfect? Okay. I'll explain more in detail. So before I go into the specifics of the direct pathway and indirect, I want you guys to understand the configuration of it all, okay? So you have the cortex, the neurons in the cortex, when they go to two areas of the basal ganglia. They go to the striatum, which is the caudate and the putamen, and they go to the substantia nigra, pars compacta. So there's two parts to the substantia nigra, pars compacta, pars reticulata, okay? So the cortex releases glutamate. So these neurons only release glutamate. That means what? They stimulate these structures to modulate movement. The striatum, which is caudate and putamen, when it's stimulated by the cortex, it only releases GABA. So it's mainly inhibitory. There is a slight excitatory neurotransmitter that can be released from striatum, but it's mainly inhibitory, it's mainly GABA. And the striatum, I'm not talking about direct and indirect right now, I'm just talking about in general. The neurons of the striatum, they project to three areas. You have it projecting to the globus pallidus externus, globus pallidus internus, and the substantia nigra, pars reticulata, okay? So it's really hard to understand it at first, so please go back to the slides when you need to, but I'm just showing you the configuration, okay? Now, the globus pallidus externus, it projects to, this one, the externus of the globus pallidus, it projects to the subthalamic nucleus, and it releases GABA as well. So neurons of the globus pallidus externus only release GABA to the subthalamic nucleus. The globus pallidus internus, it goes directly to the thalamus. Remember how I told you the GABA from the at rest comes from the globus pallidus internus and the pars reticulata of the substantia nigra. So both these structures, they are directly, the neurons, they directly go to the thalamus, and then that goes to the cortex, and they only release GABA. The subthalamic nucleus, it releases glutamate, however. This is the subthalamic nucleus, and it goes, the neurons, they synapse with the globus pallidus internus, which is this one. Okay, so this is confusing, you're not going to remember it, but I'm just showing you now, so that when I say the direct pathway and indirect, you know that specific, in this area, these neurons go to this area, these neurons go to that area, and they release these specific neurotransmitters. It's not like they're all connected. Not all basal ganglia structures are connected to each other, right? So they're specifically reaching out to these specific areas and releasing these specific neurotransmitters, okay? So now on to the gist of it, okay? So direct and indirect pathway, which occurs simultaneously. So you have your premotor cortex saying you want to grab the microphone. So it will stimulate your striatum. Green is stimulatory, it's glutamate, okay? Red is GABA, inhibitory. And then blue is dopamine, which is by, you guys remember? Substantia nigra, which is dopaminergic pathway, right? So here you have the cortex premotor stimulating your striatum. Striatum is now stimulated. It wants to stimulate certain muscle groups and inhibit others, right? So through the direct pathway starts by the striatum sending GABA to the globus pallidus internus. Why? Because I want movement. I want the globus pallidus internus inhibited. I don't want it to give GABA to the thalamus, right? I want the thalamus to be stimulated so that it can stimulate the cortex for movement. Okay, so again, striatum for the direct pathway to cause contraction of the muscle groups that you want to move. It will dump GABA on the globus pallidus internus. So then now the globus pallidus internus is not sending GABA to the thalamus. Thalamus is now free to release glutamate to the cortex and stimulate it to generate movement, which is the finger flexors, okay? For the indirect pathway, which occurs simultaneously, right? This is for inhibiting the extensors. This for simplification purposes, right? So the striatum, through the indirect pathway, it's going to dump GABA, because remember, striatum is primarily inhibitory, it only releases GABA. It's going to dump GABA now, not on the globus pallidus internus, but on the globus pallidus externus, okay? Why? Because normally, we said the globus pallidus externus, it projects to the subthalamic nucleus and it releases GABA. So if I'm here inhibiting the globus pallidus externus, the subthalamic nucleus is now free to release glutamate on the globus pallidus internus. So what does this cause? globus pallidus internus releases GABA to the thalamus to inhibit the finger extensors, let's say. Okay, so in the end, direct pathway, you're inhibiting
The globus
The globus pallidus
internus, okay? And the indirect pathway, the end product, you're stimulating the globus pallidus internus, right? So just think of it at rest. So at rest, you're having GABA from the globus pallidus internus and the pars reticulata. So if I want to inhibit the finger flexors, I'm going to increase this. I want more GABA to go to the thalamus for these muscles. And then for the ones that I actually want to move, which is the finger flexors, I want to inhibit the globus pallidus internus. So it's going to be the opposite. Inhibiting, stimulating.
So there's going to be both happening at the same time.
Both happening at the same time, and they involve specific neurons that project to the thalamus. That thalamus projects to certain neurons of the cortex, which then activate specific muscle groups. Right? It's really confusing, but you generally understand a little bit, right? I can repeat it,
Can
okay?
you repeat just the indirect?
Of course, I'm going to repeat this until you get it, okay? I just want to also add, so again, the direct pathway, just a summary, direct pathway is for stimulating the finger flexors, just for you to remember, okay? And direct, inhibiting the extensors and any other muscle groups that you don't want to move, tamam? Okay, that's the direct and the indirect. Also, you have the pars, the substantia nigra, which we call it like a side part or a kickstarter. What does it do? The substantia nigra acts on both the direct and the indirect. How? It releases dopamine to the striatum, and this dopamine will increase that direct pathway. What does that mean? You're going to have more GABA from the striatum to the globus pallidus internus, and therefore you're going to have the globus pallidus internus inhibited so that you generate that movement. At the same time, the substantia nigra pars compacta releases dopamine to the striatum to inhibit the indirect pathway. So the substantia nigra compacta, in the end, it wants movement because it would make sense to say, oh, it wants to increase the direct and increase the indirect, but it doesn't. It increases the direct and it decreases the indirect. So if you're decreasing the indirect, it causes more excitation, صح? So the substantia nigra pars compacta, the net, let me show you the slide, maybe you'll be able to get it. The net result is an increase in motor activity. And let me make it more simplified for you now. Parkinson's disease, you have degeneration of these cells, right? The pars compacta. What does Parkinson's disease present with? Pill rolling tremor, but before that, though, what's the kinesia? What type of kinesia do they have? Bradykinesia. That means they have slow movements, right? Why? Because the pars compacta, what's the net result?
It's
Increasing motor activity. So if I have degeneration of the pars compacta, it's going to decrease motor activity. It's going to lead to that bradykinesia, correct? Okay, so understanding what each part does will help you understand because you're going to know this in the next lecture, the Huntington's disease and Parkinson's and Wilson's. So those diseases, they affect specific parts of the basal ganglia and will lead to specific motor abnormalities. Okay, let me go one more time. Let's see if you get it.
Where's the other diagram? I think it's more.
Other diagram?
The one before.
This one?
Yeah.
Should I use this one?
Yeah.
Okay. So premotor cortex stimulates the striatum. Striatum, red is for inhibitory and GABA, okay? Striatum, through the direct pathway, will release GABA on the globus pallidus internus, okay? And I forgot to mention also, and the substantia nigra pars reticulata, because remember, both these two structures at rest, they release GABA to inhibit movement. So I don't want them at rest to inhibit this movement. I want my finger flexors to work, specifically finger flexors. So that's why they dump GABA on these two structures. Therefore, they're not releasing GABA to the thalamus anymore, and you have the thalamus free to activate the cortex. That's the direct pathway. Indirect pathway is when you're having the inhibition of the finger extensors. So here, you're going to have the striatum not going to the globus pallidus internus. It's going to dump GABA on the globus pallidus externus, okay? And externus, normally, it inhibits the subthalamic nucleus. So if I'm now inhibiting the globus pallidus externus, that means it's no longer inhibiting the subthalamic nucleus. Subthalamic nucleus is now free to activate the globus pallidus internus and the substantia nigra pars reticulata. So you see the difference? The indirect wants these two things to release GABA to the thalamus for those specific muscle groups that you don't want the movement of, the finger extensors. Whereas the direct, it wants to inhibit these two structures so that the thalamus is free to stimulate the cortex. The pars compacta is what's a little bit confusing, okay? And I'll try to explain to the best of my abilities, but the pars compacta, where is it? It doesn't, oh, it's right here. So the substantia nigra pars compacta, I also forgot to mention the D1 and D2 receptors. So the pars compacta releases dopamine, right, to the striatum. Now, this dopamine, when it binds to neurons in the striatum that contain D1 receptors, these D1 receptors, they increase the direct pathway. They increase the excitation, okay? When the dopamine binds to D2 receptors on the neurons of the striatum, then it will lead to an increase in the indirect pathway. So the striatum has these neurons, and they either have D1 receptors or D2. If I have activation of D1, what will it lead?
Direct.
Increase in direct, increase in excitation, so that you have, so basically it's like a Kickstarter. It's telling the striatum, I want the thalamus to work, you know? So it's a Kickstarter, it magnifies the whole direct pathway. It increases its, activity. Whereas the D2, it's going to inhibit the indirect. So if I'm inhibiting the indirect, that means it decreases the inhibition. So that means that it increases the excitation. So again, the net motor result for the substantia nigra pars compacta is an increase in motor activity. So that's why when there's degeneration of these neurons, you're going to have bradykinesia, like in Parkinson's. Okay? What else I want to say?
So in an indirect, we're basically stimulating the GPI and SNR so that they can inhibit the thalamus.
بالضبط.
And in the direct, we're inhibiting the GPI and SNR so that the thalamus can.
بالضبط, exactly. You guys understood it now? Okay, and then explain to me the substantia nigra pars compacta, just to make sure everyone. Yeah, pars compacta.
Yeah, the SNC.
Yeah.
Okay, so when we're inhibiting the indirect, alright, that means that the GPI and SNR are also going to be inhibited and more stimulation is going to happen in an indirect pathway. But if you're going to stimulate it through D1 receptor, you're going to continue stimulating the direct, and that's going to lead to more stimulation, inhibition of the GPI and SNR in the direct, and that's going to lead to more thalamus going to work.
Okay, so yeah, basically. So D2 will lead to decreasing the indirect. So you have more excitation of the GPI. No,
more inhibition.
More inhibition, okay? So more inhibition of the GPI so that you have more excitation. It's so confusing, I know. Do you have a question?
Yeah, Doctor, can you explain the pars compacta part again?
Pars compacta, okay. So what I like to think of it is, like, I also was like, why does it inhibit the inhibitory pathway? Why does it inhibit the indirect pathway? Because if you want to think about it, too much inhibition can be bad. So pars compacta is basically like refining it. It's saying don't inhibit those muscle groups too much because maybe they want to move it. That's how I like to think about it. Okay? So this is why the substantia nigra pars compacta, when it releases dopamine, because it only releases dopamine, right, to the striatum, which is also called the nigrostriatal pathway. You guys remember in the dopaminergic pathways. So it releases dopamine into the striatum. If it activates the D1 receptors, the neurons with D1 receptors, it will lead, because it does both, by the way. We said it occurs simultaneously, direct and indirect. So here it will lead to two things. It will increase the direct pathway excitation. So that means you're going to have more finger flexion, okay? And then it decreases the indirect pathway. So the indirect pathway is when you're having the inhibition of the finger extensors. So here it's decreasing that inhibition. I'm having less inhibition on the finger extensors, that means I'm having more excitation, a little bit more. It's not a lot, it's a little bit more. Okay, so the net motor activity for the substantia nigra pars compacta, let me show you here, is an increase in motor activity. Okay? If I compare it to the pars reticularis, remember at rest we said the pars reticularis and the internus, they both release GABA at rest to prevent any unwanted movements. The pars reticularis releases GABA, so the net result of it is that it decreases motor activity. Right? If I compare it to the pars compacta, which is the net result, increasing motor activity, remember, it increases the direct pathway, decreases the indirect. Altogether, increases excitation. The subthalamic nucleus, this is the one that's a little tricky and I have an MCQ on it, but subthalamic nucleus, I told you it releases glutamate, right? But what pathway is it involved in? Can you guys remember?
Indirect, I guess.
Indirect, right? So it releases a stimulatory neurotransmitter, but it's involved in the indirect pathway. How does that occur? Because we said that the globus pallidus externus, normally it inhibits the subthalamic nucleus. But when you're having the indirect pathway, it's going to inhibit the globus pallidus externus. Therefore, the subthalamic nucleus is free to activate the GPI, and then the GPI releases the GABA on the thalamus. Okay? So in the end, it's decrease in net motor activity. Okay? Honestly, you have to keep repeating this in your head at home to fully understand it. You're not going to understand it in the get-go. But if you want me to explain any further things, let me know.
I kind of feel that this diagram is a bit misleading for some reason.
This one?
Yeah.
Yeah, I like this one more. Because it also tells you the structures in terms of like the anatomy. You have the striatum, the globus pallidus, and externus, internus, substantia nigra, and subthalamic. So try to go off of this pathway more than the other one, but they both say the same thing. I also have, I think, another diagram. This is not as... There's this one. I'll explain on this one and then I'm going to move on, okay? Is that fine? One last time. Okay. So the premotor cortex says, I want to move this microphone, okay? It stimulates the striatum. Both occur simultaneously, the direct pathway and the indirect, okay? The direct pathway will stimulate the finger flexors. The indirect pathway will stimulate the finger extensors, okay? Now the motor cortex stimulates the striatum and for both pathways, direct and indirect. The striatum is now activated. And we said striatum is primarily inhibitory. It only releases GABA. So the striatum, for the direct pathway, it's going to release GABA directly on these two structures over here. Why? Because at rest, these two structures, they release GABA and they prevent movement. And here in the direct pathway, I want movement for the finger flexors. So the striatum will inhibit these two structures. Therefore, these two structures, the GPI and the substantia nigra pars reticulata, they no longer send GABA on the thalamus. Thalamus is now free to send glutamate to the primary motor cortex, not the premotor, the primary. And then now you have generation of the finger flexion, right? For the indirect pathway, which occurs simultaneously, here I'm going to have inhibition of the finger extensors. I don't want them to work because I want to flex my fingers to grab the microphone. So here the premotor cortex is thinking about grabbing this microphone. It stimulates the striatum by releasing glutamate. Remember I told you the motor cortex, or the cortex, always releases glutamate. Right, so go over these. It's really, I feel like it really helps you to understand. Okay, so it releases glutamate, and then the striatum, and the indirect, so the direct we understand it, it's so simple. You're inhibiting the globus pallidus internus and the pars reticulata, which are what happens at rest, because you want movement. But for the indirect, it's like, they're going through so many different structures, but basically it starts at the globus pallidus externus. The striatum sends GABA to the globus pallidus externus. Now the globus pallidus externus is not sending GABA onto the subthalamic nucleus. Subthalamic nucleus is now free to release glutamate onto these structures, so that now you have these structures being able to release GABA on the thalamus, and therefore the thalamus now would be inhibited, and the thalamus would be inhibited so that you don't have the finger extensors being stimulated, right? They're inhibited, okay? Is this a better diagram?
Yes.
Okay. So let's...
The CNC, I think that's the confusing.
Yeah, the CNC, okay. Is it here? Okay. So here, the direct pathway, you have the substantia nigra pars compacta, and we said it always releases dopamine, the pars compacta. Pars reticularis releases what? GABA, perfect. So the compacta, it releases dopamine. This dopamine, when it binds to the D1 receptors on the neurons of the striatum, it will increase the direct pathway. This dopamine, the same dopamine, when it binds to the D2 receptors of the neurons in the striatum, it will inhibit the indirect pathway. Because I don't want too much inhibition on my muscles. I want, like, what if I suddenly want to extend my arm? If I have this indirect pathway increasing this inhibition on the finger extensors, I'm not going to be able to move my arm when I want to, or like to extend it, right? So that's the gist of it. So the D2 receptors, they inhibit the indirect pathway. The D1 receptors, they stimulate the direct pathway. They increase the excitation. Perfect. Let's zoom through. So this is just in writing, if you guys want to read through it to understand it better. I hope it makes sense in the end. Okay, so let's test your knowledge quickly. So the pars reticularis, what does it do?
It releases GABA and inhibits
And causes
the
increased-
thalamus.
Okay, so what is it? Which letter? B. Perfect. Okay, now this one. So actually, I'm gonna skip this one and I'll go back to it because it requires explanation. But let's do this one.
Release of dopamine.
Internus. No.
Was it palace? Oh, that was compatible.
It's it's a direct pathway, right?
Yeah.
So if you're gonna inhibit this, the GABA is gonna be the.
Always think about it first at rest. That's how I like to do it. At rest, what happens?
GABA is released.
GABA is released by which two structures?
Internus and
C.
Reticularis. This central intra. So what is it? What is internus? What does it release at rest?
Internus is gonna release GABA. So if you're gonna inhibit it, no GABA release.
Yeah, perfect.
So it's gonna be increasing
Yes.
the thalamus.
So inhibition of the globus pallidus internus, if you inhibit it, you're going to have increased GABA release. No.
No, you
No,
should
there
have
is no
Inhibition.
GABA release, but activation of the thalamus.
Yeah, this one, glutamate. You're going to have, so inhibition of the you're inhibiting the globus pallidus. It's no longer sending GABA to the thalamus. So now the thalamus is free to stimulate the cortex. So it's A. Let me make sure.
Yes.
Yeah, A. Okay. So I explained this slightly, but there's a structure that releases an excitatory neurotransmitter. Yes.
C.
Yes.
Spinal
Subthalamic. Perfect. So it releases what?
It's gonna secrete GABA.
Yeah.
Dopamine. I remember it.
Yeah. But dopamine is pars compacta only. Think of it as Parkinson's and think of it of the
So-
dopaminergic pathways.
Wait, I guess.
I'll show you 1 second.
Glutamate.
So go back to this. See? So the cortex releases glutamate.
No.
Striatum GABA, GPE, GPI both GABA. What releases glutamate? Subthalamic, right? And then at the end, subthalamic we said is involved in the indirect pathway. So always think of it, indirect inhibition. So it's releasing glutamate, but in the end product it's causing inhibition. Okay? So it's subthalamic. You got the answer right, but okay. So which of the following basal ganglia structures directly inhibit the thalamus? Internus. At rest. Always remember at rest. What happens? And then this one. Which one?
Compacta.
Compactus. Stop answering.
Oh, sorry. Because I'm learning this
I'm
I
just
swear.
Okay, high frequency brains. I'll explain this in a minute. This one. The indirect pathway of the basal ganglia involves which of the following?
Inhibition of
Yeah, it is.
It's
C.
Is it C?
See, it's not inhibition of the globus pallidus internus. You activate the globus pallidus. You inhibit the globus pallidus, guys. You're confusing me. 1 second.
Isn't it inhibition?
So I'm not going to look at the answer choice because I want you guys to think about my thought process, okay? So the indirect pathway starts at the motor cortex. Then it stimulates the striatum. Striatum then releases GABA onto the globus pallidus externus. Globus pallidus externus is now not able to send GABA onto the subthalamic nucleus. Subthalamic nucleus is not able to release glutamate to the globus pallidus internus. So then globus pallidus internus now is stimulated to release GABA onto the thalamus. Thalamus is now inhibited. Okay?
So why not A?
Yeah, it is A. You're right. I thought you said the one before. It inhibits the thalamus. So you're not having movement. If you have inhibition of the thalamus, you're not having movement. That's
So
the
it
indirect
also
path.
activates the globus pallidus.
No, it inhibits it actually. If you remember the pathway, you see the red line. So it inhibits the globus pallidus externus. Now the globus pallidus externus is not releasing. Did you like this diagram better? What did that one before?
The dirty medicine.
This one? Okay. So here, the motor cortex stimulates striatum. No, indirect. Motor cortex stimulates striatum. Striatum now inhibits globus pallidus externus. It's not able to release GABA on the subthalamic. Subthalamic now free to release glutamate and activate these two structures. which then release GABA. Okay? So in the end, indirect. What happens to the thalamus? Inhibited or stimulated? Inhibited. Indirect inhibition. Okay? Direct stimulation. Stimulates the thalamus. So yeah, you move. Okay? Okay. I'm gonna quickly go over brain stimulation because I'm scared the next topics don't cover this. But when someone in a USMLE exam says you're stimulating an area, it does not mean you're stimulating it, making it more active. It means you're inhibiting it instead. Okay? So in a patient with an essential tremor, that means that they are hyperactive. There's an increase in movement. I want an area to target to inhibit it so that I decrease this increase in activity. Which area?
D.
No.
Why not
No,
B?
but if you
Which area do I inhibit so that I don't have this increased activity?
Turnus.
No.
Thalamus? Turnus.
B?
I want to inhibit the extra.
Who said? Someone said it.
A.
B?
A, thalamus. A, thalamus. So basically,
cause like increase.
what would I inhibit to prevent an increase in movement? Thalamus, we said it wants to stimulate the cortex to generate movement. So if I inhibit it, I'm not going to have movement anymore, and therefore the essential tremor will decrease.
Because globus pallidus and turns already releases GABA. Oh my god, okay.
It's fine, I know, well, it hurts your brain, I'm telling you. But once you keep repeating it to yourself, you'll understand it. Okay, so now another high frequency brain stimulation question. Last one. So here you're having Parkinson's, which is bradykinesia. So this is decrease in net motor activity. Which area would I inhibit so that I would have an increase in motor activity?
C.
Perfect.
Do I
Perfect.
get
You understood it now?
Yeah.
Samai?
She wants a lollipop, right?
I would
The
love to.
blueberry one.
Which one?
The blueberry, please.
Blue one? Okay.
I think they're done. There's the
This
color
one?
one. Yeah.
Oh, okay. So, I don't want to take too much of you guys' time, but read through this if you guys would like to.
How long will the cerebellum take?
I have no idea. I'm going to zoom through.
It's recording, don't worry. Can I leave?
Yeah, you can leave it.
Okay, thank you. And thank you so much for.
Of course. Okay, so now onto the cerebellum. So the cerebellum is located right above the foramen magnum. What is that?
The opening of the skull.
The place where the brainstem is. It's basically the place where the brainstem is usually located.
Yes, perfect. But what is it? Where's the opening? It's an opening.
The
Which
skull.
skull? Which bone? Occipital. Okay, so yeah, so it's an opening in the occipital bone. Right above it is the cerebellum, and the cerebellum is right below the cerebrum. It's right below the occipital and temporal lobes, and it's covered by a dura fold, which is a tentorium cerebelli, and that separates the cerebrum from the cerebellum. And what also separates the cerebrum from the cerebellum? It's the transverse fissure. So remember this. There's a transverse. Let me show you. So there's this transverse fissure that separates the cerebellum from the cerebrum. What is the name of this fissure? Preterm material?
Sylvius. Lateral.
Lateral. Okay, so don't confuse the lateral with the transverse. Okay. Okay, the cerebellum is connected to this brainstem through 3 peduncles. What is a peduncle? Does anyone know?
Track of fibers.
Yes. So peduncle are these bundles of nerve fibers, and there's 3 of them. So if you see here, the brainstem is connected to the cerebellum through these. You won't be able to appreciate it as much, but you see there's like these peduncles entering into the cerebellum. And there's 3 of them. There's superior, inferior, and middle. Okay, what else? What else? So the function of the cerebellum is 3 main things, and this is really important for the symptoms. So it helps to control your balance and posture, helps to coordinate your movements. This is what we mentioned before when you're trying to reach for something or doing like reaching or writing with the pen. So these are fine motor movements, and that is the smooth pursuit of it is by the cerebellum, and then it also maintains muscle tone. So if I have problem with the cerebellum, I'm going to have problem with balance. It will lead to what? Ataxia. And if I have a problem with the cerebellum, it will lead to uncoordinated movements, which will lead to what? What is that called?
OS.
Yes, exactly.
Which
Which one? Dysmetria. So it's up also is part of it. So dyscernia is what you said is Under it is three things, okay? Which I have a slide for it. But basically, there's the finger to nose. That's the one that tests finger coordination. And there's the heel to chin test. This is in step 1. So basically, we're just telling them to take their heel and to go down their chin like that. It's like finger to nose, but for lower limbs. Tamam? Okay. And then if there's a problem with the cerebellum, it will affect muscle tone, and it will lead to what? Hypo or hypertonia? Hypo. So here it's maintaining that muscle tone. So if I have the cerebellum affected, I'm going to have a decrease. So it's hypotonia.
Okay, doctor.
Yeah.
What's tentorium over here?
So tentorium cerebelli, do you know the dura mater? It has 2 layers. The endostele. Did you guys take it or not yet?
I remember tentorium.
We did.
Yeah.
So you have, so it's okay. You have the 2 layers of the dura mater. There's the endostele and then there is the meningeal. So the endostele, I think, is the one that invaginates. And it divides the cerebrum and the cerebellum. And then also the same fold is what goes in between the 2 cerebral hemispheres, and it goes like that. Right? So this dura mater fold is what divides the cerebrum and the cerebellum, and also what divides the 2 hemispheres. Okay? But it's really important also, because sometimes you would say supratentorial, infratentorial, and that's according to the tentorium cerebelli, which is the fold of dura mater. Okay. Okay. So anatomy, real quick. So you have 3 lobes. This is the anterior lobe. It's tucked into the cerebral hemisphere, right? So sometimes hard to see. It's located, so this is, I'm looking at, the view is posterior lateral. This is the posterior side of the cerebellum. This is anterior. So this is the anterior lobe, right? And it's very anterior and it's the most anterior and the most superior lobe. This whole thing is the posterior lobe. It's very large. And then you have this small lobe called the flocculonodular lobe. It consists of 2 parts, the flocculi and the nodulus. So this is the flocculi, it's located laterally. And then you have the nodulus, which is located more medially. I'll show you a cross section. And then you have 3 fissures. The primary fissure would divide which 2 lobes?
Anterior.
Perfect. And then you have the horizontal fissure, which divides what? Posterior lobe into upper and lower portions, because it's such a large lobe. And then you have the posterior lateral fissure. You're not able to appreciate it, but it divides the flocculonodular lobe from the posterior lobe. I'll show you in this cross section. So anteriorly, quick, you're going to see all the lobes, anterior, posterior, and the flocculonodular. So this is the flocculonodular lobe. It consists of the 2 flocculi over here and the nodulus. Okay? This is the posterior lobe, and this is the anterior lobe. What are these? Do you guys know? Peduncles, perfect. So these are the things, because remember we said the brainstem is attached to the cerebellum, right? So the brainstem attaches to the cerebellum anteriorly. So of course you're only going to be able to see the peduncles anteriorly. Same with the flocculonodular lobe. It's the only lobe where you're only able to see it anteriorly, versus the other 2 views, the posterior, you're able to see a little bit of the anterior lobe and the majority of the posterior lobe. And same with the superior view, you're able to see the 2 lobes but barely the flocculonodular lobe. Okay, and another way to differentiate these the views is through the shape. So anterior and posterior, you see this triangle appearance, right? So it's like a triangle, versus superior, if I'm looking at the cerebellum superiorly, it's more crescent or wedge-shaped. Okay, so this is a cross-section. You can see the fissures, right? The primary, which divides the anterior lobe from the posterior. You can see here is the horizontal fissure that divides the posterior lobe, and here is the posterior lateral fissure, which divides the flocculonodular lobe from the posterior lobe, okay? This is the most important thing, and I think that's the only thing I'm going to focus on, is the vermis and the hemisphere. So the vermis is just the midline structure of the cerebellum. So it spans through both the anterior and posterior lobe. Hemispheres, they're located on both sides of the vermis, and they represent the lateral portions of the cerebellum, right? If I have a lesion in the vermis, it presents differently compared to lesions of the hemisphere. This is the most important thing, okay? So you have a lesion in the vermis called a central lesion, and a lesion in the hemisphere called a lateral lesion. And I'll tell you what each one means. I'm not going to go into this, but just one thing. What are these called? Tonsils. What's right below them?
Midbrain.
Foramen magnum.
Yes. So if I have an increase in intracranial pressure, what's going to go down through that foramen magnum? The tonsils. So the tonsils are the most inferior portion. That's why when there's an increase in intracranial pressure in the brain, there's an increase in pressure. It's going to cause herniation of these tonsils through the foramen magnum, which is what the cerebellum sits right on top of. And the foramen magnum is the opening that circle on the occipital bone, right? Yeah, and this is the vermis, right? This is called the superior vermis, and this is called the inferior vermis. So, which fissure separates the cerebellum from the cerebral cortex?
B?
Which one?
No, D.
D. Yes, transverse. Which are separated by the primary fissure?
A.
Yes, anterior and posterior. Which structure is likely to herniate through the form?
The tonsils.
Tonsils, perfect. Okay, so now on to the functional areas. This is just as important as vermis and hemisphere. So central lesion, lateral lesion. Here you're also able to differentiate lesions of the cerebellum based on functional areas. Do you guys remember Brodmann area? How there are these groups of neurons, same function? Same thing here. There is this area, the one in green. These neurons, they have similar function, which is what? They take that proprioceptive information from the body, and from that, they coordinate movements. This area is called the spinocerebellum. So it makes up the anterior part of the anterior lobe. Oh, sorry, this is not part of it, managed. This is blue. So the spinocerebellum makes up the anterior part of the anterior lobe, as well as the entire vermis. So if I have a lesion in the vermis, what would it present with? Spinocerebellar damage, basically. Okay, and I'll also tell you what the symptoms are, okay? The cerebrocerebellum, it makes up the majority of the posterior lobe. You can see it here, right? And here it's involved in fine motor coordination, which is the finger to nose and the heel to chin. These are fine motor movements, as well as this one. This is what we call dysdiadokinesia. So the ability to do rapid movements on their palm is also fine motor. So if I have a problem with the cerebrocerebellum, I'm going to have the patient, when they do finger to nose, they're going to overshoot or undershoot. And then when I tell him to go to his nose, because remember, fine motor is when you're reaching for the target. It's not like gross motor where you're walking. Fine motor is like I'm writing in a pen, I'm reaching for something. So when I tell them to touch their nose, they start to shake. What is that called? So when I tell them to go reach for something, they start to shake. What is that called? Do you guys know?
Intention tremor.
Intention tremor, perfect. So that means once they go close to the target, they're not able to have that fine motor movement, they start to shake, okay? So that's the cerebrocerebellum problem, tamam? And then lastly, you have the vestibulocerebellum. This is the easiest one to remember because here it makes up the entire flocculonodular lobe. And this lobe, it gets information from the vestibular nuclei. Remember in the brainstem, there are these vestibular nuclei and they receive information from the inner ear. What is the inner ear involved in? It's involved in
hearing and balance.
balance, perfect. So here, if I have a problem in the flocculonodular lobe, it's going to lead to balance problems. It's also going to lead to eye movements problems, which is what? Nystagmus, okay? I'll show you now. So again, lesions of the spinocerebellum, which affects the vermis, you're going to have difficulty doing walking movements. So they're going to have a wide base gait. This is very classical in cerebellar disease. So why do they have a wide base gait? It's not because they have loss of proprioception. That's for when the dorsal column is affected. Here, it's because they're not receiving that proprioception to then coordinate movements. So here the problem is their movements are uncoordinated. They have truncal ataxia, or they have some form. So I think it's like I call it like a penguin. So it's like this, and they're shuffling. So the only way they're able to maintain balance is by having a wide base gait and by going like this. That's the only way because they have that loss of proprioception going into the cerebellum. Do you guys know the difference between spinocerebellar tract and the spinal and the dorsal column in terms of proprioception or no? So dorsal? Yes. Do you want to explain? So the spinocerebellar tract goes from the spinal cord to the cerebellum, right? And this tract it carries proprioception. The specific type of proprioception is unconscious proprioception. So for example, the information from my tendons, from my muscles, all of this I'm not conscious of, right? I don't know where my joints are. My body does though. So this is all unconscious and it goes to the cerebellum. And from this information, the cerebellum is able to coordinate movements. If I don't have this information about my tendons, about where my joints lie in space, I won't be able to move, right? If my body does not know where my joints lie, how would it be able to move? So that's basically the spinocerebellar tract and the spinal cerebellum damage because it receives these neurons, they receive proprioceptive input, and if they don't receive that, if there's damage to it, then they have a wide base gait. They're not able to coordinate their movements, so the only way they maintain balance is by having this wide based gait and shuffling, okay? For the dorsal column, it's conscious proprioception. So like right now I'm walking, I know where my feet are because I can feel it, right? So conscious proprioception, you can feel it and you know where your feet lie in space. So in conscious proprioception loss, or when dorsal column loss, they present with something called sensory ataxia. Do you guys know what that is? I'll explain it later, but sensory ataxia is different from cerebellar ataxia. That's all you need to know for now. For the cerebellum damage, here we said fine motor movements are affected. They overshoot or undershoot when you tell them to touch their finger, then touch their nose, then touch your finger. And another thing is they have an intention tremor. So as they get closer to their nose, they start shaking. A damage to the vestibulocerebellum, here, like we said, it's in the name, vestibular system, right? So here it affects their ability to stand upright. Why? Because the vestibular system is involved in balance. So they're not able to stand upright, and they're not able to maintain the direction of the gaze. So they can present with nystagmus as well as vertigo. Okay? So I also wanted to mention one important thing. The cerebrocerebellum, more medial, because we said cerebrocerebellum is involved in fine motor movements and coordination, right? So the more medial is going to be involved in trunk coordination. The more lateral is going to be involved in extremities coordination. So if I have a lesion here in the distal, the finger to nose is affected because the distal extremities are affected. If I have a lesion in the midline, it's going to lead to truncal ataxia. They're not even able to sit without being wobbly because the coordination of the muscles and the trunk is affected. Okay, so just remember that. More midline, more trunk, more lateral, more distal extremities. Okay? This also goes for vermis and hemisphere, for central and lateral lesions. I'll explain it in a minute. Okay, so let's do a couple questions. So finger to nose test, what does it assess? Which functional area?
C.
C. Who answered?
Me.
Oh wow, okay. Yes, C. And then this one. Did you guys understand it? But you want me to say it one more time? So spinocerebellum is what? Try to remember. Spinocerebellum, which is the vermis, the whole midline, as well as a part of the anterior lobe. What is it involved in?
The
Proprioception, right? So it's receiving that proprioception to then be able to coordinate your movements. So if I have loss of this, they present with what type? Wide-based gait. Yes, okay. Cerebrocerebellum, if it's affected,
The
fine motor, the dysmetria and the finger to nose. More medial is going to lead to trunk in coordination, and then the more lateral
is the
distal extremities, the fingers and then the toes, or the heel-to-chin test. The vestibulocerebellum, it's in the name. Just think of it as two things: nystagmus, vertigo. Okay, because it involves the flocculonodular lobe. Okay. Here, spinocerebellum. What it will present with?
D.
D.
yes.
Right. C is what?
C is
Cerebrocerebellum.
Perfect. Inability to. This one's kind of hard, but inability to stand upright is going to be mainly with vestibular. Yeah. And then difficulty maintaining eye fixation. Vestibular. Okay. Which lobe contains the vestibulocerebellum? It's a very small. Yeah, very small one. Okay. The one for anterior lobe and vermis is the spinocerebellum, and the one for the posterior lobe is the cerebrocerebellum. Okay, so this is just a question to show you an example. You're not gonna answer, but this patient has this stroke in the right cerebellar hemisphere as well as the vermis, right? So now I'm thinking, okay, it's affecting a little bit of the vermis. That means a little bit of which functional area is affected? Spinocerebellum. And then at the same time, it's going into the hemisphere. So which lobe is? Cerebrocerebellum, right? So they present with a wide-based gait because the spinocerebellum is affected. And they also are not able, they start, when asked to stick his arm out in front of him and touch his nose, he begins shaking uncontrollably. And this is because of the cerebrocerebellum damage. Okay? This is going to be okay. So the peduncles, we said there's inferior, middle, and superior. The middle and inferior, they input into the cerebellum. So these peduncles, they contain only axons. They're white matter tracts. Middle and inferior, they take information information to the cerebellum, and superior takes information out of the cerebellum. Very easy to remember, okay? Middle inferior to, superior out. Okay, so the inferior cerebellar peduncle, the one thing that I want you to remember, don't read into this, just know that it carries ipsilateral proprioceptive information. So if I have proprioceptive information of the spinal cerebellum on the right side affected, which cerebellum hemisphere is affected? Right or left? Right, so same side, okay? It does not desiccate, it does not cross. Okay?
It does in the middle.
Yeah, spinal cerebellum.
Oh, yeah, Spanish cerebellum.
Yeah. So here it's showing you the inferior cerebellar peduncle. It gets proprioceptive information. And just for your information, the vestibulocerebellar tract also goes within this peduncle, and then it goes in here. Now axons, they have to synapse with what? Neurons, right? Cell bodies. So the Purkinje cells are those cell bodies of the cerebellum, and then these Purkinje cells, they project to something called the deep nuclei, which then they go out through the superior cerebellar peduncle, and then to the other side of the cortex. Okay? If you need to leave, it's completely fine.
Is there anything important, like super important that I need to know?
Okay.
Like,
There was, it's towards the end.
okay, I'll record it.
Yeah, okay. So the middle cerebellar peduncle is also in or out? In or out of the cerebellum? In. So remember the box. Middle inferior peduncle and superior out. Okay? So this middle cerebellar peduncle, just know that it carries pontocerebellar tract fibers. So there are these fibers from the pons to the cerebellum, and it's contralateral. It's not ipsilateral. This one is very low yield. You don't really have to remember much. I'll also skip this because I don't think you need to. So the superior cerebellar is the out peduncle, right? So it's the major pathway out of the cerebellum to the contralateral cortex. And these axons, because we said peduncular axons, they come from the deep cerebellar nuclei, and I'll tell you what they are in a minute. So all outlets, to be able to leave the cerebellum, they have to leave through the deep nuclei, and then through the superior cerebellar peduncle. And then after that, the superior cerebellar peduncle, which are axons, they go to the thalamus and the red nucleus. Which structure I talked about before also goes to the thalamus and then helps in modulating movements and stuff like that? Dorsal column? I just thought. And so which structure in the brain goes to the thalamus and then it modulates movement? I talked about it before cerebellum. Basal ganglia, right? So it's the same thing. So cerebellum and basal ganglia kind of work simultaneously. They both go to the thalamus and they tell it to fix movements or to coordinate movements. Specifically, cerebellum is for coordinating movements, like sequential, and then basal ganglia is for inhibiting and activating certain muscle groups. So these are the deep nuclei. You have four. There's the dentate, which is the most lateral. There's the interposed nuclei, which consists of two, the globus and the umbiliform. Then there is the vestigial, which is more central. So the interposed and the vestigial are more midline, which is what? Located where? The vermis or hemisphere? Vermis. And then dentate is more lateral, located in hemisphere. Okay, so I told you before you can determine based on the patient's symptom whether he has a spinocerebellum damage or dysfunctional area damage. Another way to differentiate it is through the vermis and the hemisphere. So let's go here. Wait, this is really important actually. So the cerebellum, it gets proprioception from the same side, right? The cerebellum, the fibers, which is the superior peduncle, it goes to the contralateral cortex. So if you remember this image here, you have the superior peduncle, cerebellar peduncle, it goes to the contralateral cortex. Okay? But the contralateral cortex crosses off to the other side. So in the end, the right cerebellar hemisphere represents which side of the body? Right. And the left? Left. Okay? Because it crosses twice. So it's going to represent, so if I have a right cerebellar hemisphere damage, it's going to affect my right side of the body, and vice versa. Okay? So now on to the gist of it, okay? So the lateral lesions are when you involve the hemisphere. Which one makes up the majority of the hemisphere when we talked about the functional areas? Posterior lobe, which is what? Cerebrocerebellum, right? So you can kind of combine these two things, right? So here, lateral lesions, they typically affect the extremities, I told you, right? So the more lateral, the more the extremities are affected. And the more medial, the more trunk is affected. So the midline lesions, they affect the trunk. If I have damage to the dentate nucleus, which is located more laterally, it's going to represent as a lateral lesion, which affects the extremities. If I have lesions in the vermis, or these midline nuclei, deep nuclei, I'm going to have, or at the flocculonodular lobe, I'm going to have the trunk is affected. I also forgot to mention, for the deep nuclei, they project not just to the thalamus, they project also to the red nucleus, as well as the vestibular nuclei and the reticular formation. Just FYI. Okay? So now the lateral lesions, we said it affects the extremities. It will affect the direction, the force, the speed, and the amplitude of movements. So what do they present with? Dysmetria. Dysmetria is when I tell them to do finger to nose and they overshoot or undershoot. So I have my finger here, I want them to touch it. They don't. They go above it or below it. Okay? Intention tremor is when they get close to their nose, when they get close to a target, they start to shake.
This is the lateral, right?
Lateral lesions, yes. And they can present with balance problems, and if they do, they will fall toward the injured side. So always think, cerebellar problem will affect the same side. Central lesions, we said they affect the trunk or the midline. This is when they present with truncal ataxia, where they're not even able to sit independently, they start to shake, and they can't stand independently. And then another lesion is at the flocculonodular lobe. Here it connects, like we said, to the vestibular nuclei, so they present with nystagmus and vertigo. So you just combine lateral and central with the functional areas and you're able to understand them. Okay? Okay, so the cerebellar ataxia, we said it's classically a wide-based gait. And you determine it by something called the Romberg test. So Romberg is I basically just tell them to put their feet together and to keep their eyes open. I'm going to test if they sway or they don't sway. So if I tell them keep your feet together and put your hands to the side, or you can tell them to put their hands out and keep your eyes open. If they're unsteady when doing this, and then when I tell them to close their eyes, the unsteadiness increases. What is this called? This is called sensory ataxia. This is because your eye compensates for the loss of proprioception. Sensory ataxia is when you have damage to the dorsal column. Okay? So here, they use their eyes to look at their feet and they know they're able to maintain their balance. But when you tell them to close their eyes, they start to sway. For cerebellar ataxia, I told you, it doesn't matter. Eyes open or eyes closed, their swaying is the same. So even when I tell them to do this, they're swaying a little. And when I tell them to close their eyes, it's still the same. If there's no change, there's no worsening. So that's cerebellar ataxia. And I think that's it. So they also present with hypotonia, they can, for cerebellar symptoms. They can present with something called scanning speech. So remember how we said cerebellum is involved in coordinated movements? This also includes mouth movements. So instead of saying, how are you doing? They sound like a robot. How are you doing? So they stop at every word or every syllabus. And this is the dyssynergia, which consists of these three things that we already discussed. The dysmetria, intention tremor, and the dysdiadokinesia.
This is a lesion in the lateral, right?
Exactly. Lesion in the lateral will lead to affecting this. Also think of it as the cerebellum, which is more of the posterior and the lateral areas. And then other cerebellar symptoms is nystagmus, nausea and vomiting, and vertigo. So this is just a mnemonic to help you remember the cerebellar symptoms. If you remember this in a MCQ, you're able to answer. Like if you see any of these words, you know that the cerebellum is affected. So dysdiadokinesia, ataxia, specifically wide-based, broad-based gait, nystagmus, intention tremor, scanning, speech, and then hypotonia. And this is just a summary. So just 2 questions. So a lesion in the lateral cerebellum.
Intention tremor, yes.
Yes. Perfect. So truncal ataxia is more of the vermis, midline. Same with this one, bilateral motor. And then nystagmus is of which lobe? Flocculonodular. And then here, which part of the cerebellum causes vertigo and nystagmus? B. Yes. In sensory ataxia, what can you expect to see on a Romberg test? Sensory. They compensate with their eyes.
Eye closed, B?
C.
C.
So with their eyes closed, their unsteadiness gets worse.
Oh,
And then this one, so I just want you to see, here it says cerebellar vermis is affected. And there's no midline shift, but the vermis is affected. So what would that lead to?
Truncal ataxia.
Perfect. because it's towards the midline, so the trunk is affected. And then this is the last question. So here you're seeing a hemangioblastoma in the left cerebellar, what? Hemisphere, right? So they present with what?
Right.
Left, it's
Always the same side. For cerebellum, always same side.
left is diatomalia.
Yeah. What about the rest? They make no sense, right? All of these are not cerebellar symptoms. Horner's, oculomotor nerve palsy, foot phobia, hemiparesis. And that's all the cortex problem, right? And that's it. Thank you, guys.
Thank
You can go home. Long session.
Doctor, don't kill me, but the cerebral pudendal part is a little bit confused.
I know. Okay, I can go over it one last time.
No, just on the recording because I don't want them to bully me because I usually take.
What are you trying to imply?
Not you, but Sammy, the whole bunch of stuff.
So the peduncles, it's honestly hard a little bit. But focus on Dr. Yaqin and things. He does the cerebellum, right? Dr. Yaqin, he goes in really good details. So you already,
I'll do it.
yeah. But just know that you have the two in ones and then one out. And they're just axons. And they're the ones that connect the cerebellum to the brainstem.
Yeah.
Thank
And
you
then
so
they're
much.